Welcome to week 6. We are going to cover 2 topics in class for week 6. The first one we're going to start with is communication. There is a lot of information in these PowerPoints to cover, so just bear with me and let's get started. So our learning objectives, we are going to want to identify factors that influence communication. We want to define and then describe the phases of the helping relationship. We're going to list ways in which people communicate non-verbally. We're going to want to identify behaviors that block communication. We're going to want to describe effective communication techniques when interacting with patients from different cultures. We are going to list guidelines for effective documentation. We're going to identify measures to protect confidential patient information. We're going to identify approved abbreviations and symbols commonly used for charting. We are going to describe the purposes of patient records. We're going to compare and contrast the different methods of documentation. We're going to document nursing interventions completely, accurately, concisely, and factually in order to avoid legal problems. We're going to describe the nurse's role in communicating with other healthcare professionals by reporting and conferring. And we're going to describe the nursing informatics and its contributions to nursing and healthcare. So what's the definition of communication? So communication is a complex process that involves sending, receiving, and comprehending messages between 2 or more people. It is a dynamic and ongoing process which creates a unique experience for the participants. When communication breaks down, the result can be workplace errors and the loss of professional credibility. Communication is an exchange of information. It is a skill that nurses must develop. The more complex the information or concept, the more difficult the task. So I feel like communication is extremely important in a number of areas in life, in your home environment, in your marriage, in your workplace, with your parents and children. Communication is huge, but especially when you're a nurse, when you are providing care for another human being, you want to make sure that the information that you send is understood. You want to make sure the information that you're receiving is understood, because a lot lies on being able to communicate with other people to achieve the desired results. So communication is extremely important. So communication skills assessment. An assessment of communication skills can tell you what you may need to do to be a better communicator. So it's imperative that you as a nurse be very open-minded and be very teachable. And you want to be able to look at the way you're communicating so that you can better understand what you may need to do to become a better communicator. And it's okay if you're not a great communicator. Not everybody is good at everything. What isn't okay is when you don't open your mind and you don't become teachable and you don't learn things that can affect the way you take care of other people. So it's just important that you recognize, hey, these are my weaknesses. These are the things that I forget. And then you try and work on those things to improve your communication skills. So ways that you can improve your communication skills are you can learn about how people communicate. You can, and we're going to talk about these things throughout this lecture, you can practice sending clear messages. So if you know that sometimes when you go home, that when you're at work, maybe when you're contacting a doctor, it seems like you always forget to tell him about the vital signs, or you forget maybe one part of your vital signs. Maybe you remembered respirations or temperature and O2, but you forgot blood pressure. Maybe you just forget how to do things. When you go home or at the end of your day or during your day, whenever, you can try and think of a way for you to come up with a plan so that you can send clear messages, that you will remember to include everything. So maybe you'll design a sheet. Maybe you'll have an S-bar paper, which you physically go and you write out exactly what you want to say to the doctor so you don't forget anything when you're talking to them. So that's how you can practice. You can practice listening to messages from other people. You can learn about how to communicate with people who have special needs. And then you can ask friends and teachers for constructive criticism. If you have a mentor at work, you can ask them for constructive criticism. Nursing is the field where it's completely acceptable for you to just completely not know how to do something, and it's okay for someone to teach you no matter how long you've been doing it, because it's impossible for us to know everything, and we're always growing in our practice. And the only way that you grow is to recognize the potential for growth and to ask people for help and to learn. So this is the components of the process of communication. So you have the confirmation of the message, okay, which provides feedback that the receiver has understood the intended message. You have noise, factors that distort the quality of the message, so anything that can interfere with communication at any point in the process. These distractors might be from television or pain or discomfort experienced by the patient. And communication is a reciprocal process in which both the sender and the receiver of messages participate simultaneously, okay? So you're receiving and sending back and forth between you and your patient, or you and the doctor, or you and another nurse, whoever the people are that are involved in the process. So what are the components in the process of communication? You have your sender. So the sender is the person who initiates and transmits the message. The receiver is the person to whom the sender aims the message and who interprets the sender's message. So we can use the example of the nurse and the patient. If I wanted to go in and talk to my patient about educating him on his new blood pressure medicine, I would be the sender. The patient would be the receiver. The message is the verbal and nonverbal information the sender expresses and intends for the receiver. So we have many ways to send messages. We can communicate verbally. We can communicate non-verbally without even realizing that it's happened. So you may go into a room and you may start talking to a patient, having a verbal conversation, and then you can also exchange nonverbal information. So your body language, the way that you're making contact with your patient, if you're making eye contact or if you're not, those are nonverbal forms of information. So if you go into your patient's room and you say, "How are you today, Mr. Jones?" and his head is sunken down and his eyes are closed, or he's looking off to the side and he's not smiling, he has a flat affect and he says, "I'm great." Well, the nonverbal, the actions that you see, his body positioning, the way he has a flat affect, that's considered nonverbal, and that's going to differ from what he's actually verbally telling you. So sometimes there can be a difference between the verbal and the nonverbal. We have many ways to communicate. We do voicemails, we can do text, we can do FaceTime, emails. There's person to person. You can deliver messages in chat rooms and blogs, online discussion groups. The transmission of information without the use of words is termed nonverbal communication, also known as the body language, and it often helps nurses to understand the subtle and hidden meanings in what the patient is saying verbally. So like I said, we just said to the patient, "How do you feel today?" He says, "I feel fine," but he doesn't make eye contact with you. His affect is very flat. He's looking off to the side. His body position is slumped over. His nonverbal communication is telling you something different than what his verbal communication is telling you, okay? So this is going to tell you that you need to further investigate, because there is not a, what you're seeing and what you're hearing are not on the same page. So we have the channel, which is the method of transmitting and receiving. So you have sight, you have hearing, you have touch, you have facial expression, body language. So we talked about that body language, your facial expressions. If your patient's telling you something and you're in a hurry and you feel like they're talking too much and you have to get to your next room, maybe you're rolling your eyes or you're huffing and puffing, or you just don't look like you're interested in the patient. Maybe your patient is in pain and they're not saying they're in pain, but they're crying or they're wincing or they're guarded. Those are some expressions. Touch, just offering a simple touch to your patient is part of communicating. It can really offer a lot of support and make your patient feel loved and cared for when you just, put your hand on their arm when you're talking to them. That's a huge thing. So the channel might target any of the receiver's senses. The message can be sent to the receiver through the following channels. So you have auditory, which are cues and spoken words. We have visual, which are sights, observations, and perceptions. And then we have kinesthetic, which is touch. We also have your environment, so the emotional and physical climate in which the communication takes place. So you can be an active listener and you can listen closely. You can allow your patient ample time to communicate their needs. You're going to get feedback. So the feedback is the message the receiver returns to the sender that indicates the receipt of the message. An essential component of ongoing communication can be verbal, nonverbal, positive, or negative. So the feedback is, an example of feedback would be if I was the nurse and I came in and I said, "Hi, Mr. Jones, I'm here to go over some of your discharge medications. One of your medications I'd like to talk to you about is a new medication that you'll be starting at home. It's to help control your blood pressure. Do you feel that you're able for me to be able to educate you now?" And then the patient would say, "Yes, this is a great time. I'm eager to learn. Let's talk about it." That would be a positive. Your patient might just roll his eyes and turn his body to the other way, okay? That's a clear example of communication. He's telling you he doesn't want to be bothered with what you're saying without saying any words. You can tell just by his body language. Your feedback can be positive, like the example I gave you, or negative, which was the second example that I gave you. You have interpersonal variables, so factors that influence communication between the sender and receiver, such as educational and developmental levels. So not everybody has been to nursing school or medical school, and they don't know the language that we use, what I call the nursing language. You have to talk like a nurse. So we use words that just everyday people that aren't educated in the healthcare don't understand. So we have to be conscious of their educational level, what their appropriate level is for understanding, and maybe they have developmental needs that keep them from being capable of understanding the information that we are trying to communicate with them. So we have to take those things into consideration. So we have levels of communication. We have intrapersonal, interpersonal, and then we have group. So intrapersonal is self-talk and is communication within a person. Okay, you have, and this just would be intrapersonal is going to be communication with an individual. It is a person's self-talk. It's the internal discussion when thinking but not outwardly verbalizing your thoughts. It helps nurses assess clients and situations and critically think about them before communicating verbally. So I think we've all had thoughts in our mind, good or bad, whether we want to share them or not. I talk to myself all the time when I'm walking through the house. I'll walk upstairs and I'll forget why I came upstairs, and I'll say to myself, "No, what did I come up here for?" I talk to myself when I'm driving down the road in my mind. I have thoughts in my mind all throughout the day. So that's your interpersonal communication. It's just between you and it's just in your mind. Interpersonal communication is communication between two people. So the form of communication is the most common in nursing, and it does require that exchange of information from one individual to another. Messages the receiver perceives can differ from what the sender intended. So this happens all the time. Learning how to communicate with people is, in my opinion, an art. It doesn't come easy for everyone. You have to work on it because some people may say things a certain way and not mean it the way that the person perceives it. So I might come in the room and say, "Mr. Jones, I have your blood pressure medicine here." Okay, that may mean to him that I'm too busy to have conversations with him, that I feel like I'm hurrying him, that I don't want to be taking the time to take care of him, that I'm rushing him. He might perceive it that way. It isn't how I intended it, but the way that I communicated it to him may have made him feel that way. We have to be open and understand that sometimes we say things to people that people take the wrong way. Even though we didn't mean it, we have to understand that it made somebody feel a certain way, and we have to be able to acknowledge it and change that behavior. Then we have small group communication, which is communication within a group of people, often working towards a mutual goal, such as in committees, research teams, and support groups, or just the healthcare professionals as a whole in the clinical setting. So we will answer this question when we do our live lecture. So we have characteristics of effective and ineffective groups. So group identity. Members value and own the aims of the group. The aims are clearly articulated. The group aims are not of major importance to members. Okay, so that was an example of ineffective and effective. So the effective characteristics in group identity are the members value and they own the aims of the group. Whatever everybody else says in the group is important, and we clearly articulate what we want to accomplish. Ineffective characteristics would be that the group's aims are not of major importance to members. So cohesiveness, characteristics of effective cohesiveness would be that members generally trust and like one another. They are loyal to the group. They have a high commitment and a high degree of cooperation. An ineffective characteristic would be that members often feel alienated from the group and from one another. There's low commitment, and members tend to work better alone than when in the group. And you can see this as an example. I'm sorry, you guys aren't even on the right page here. I forgot to click it. You guys will be able to see this throughout your work setting, depending on who you work with and what kind of committees you're on. Things don't always go as planned. Not everybody's always on the same page. Not everybody gets along with each other. This is where good communication comes into play. So then you have patterns of interaction. So effective characteristics would be honest, direct communication, which flows freely. Members support, praise, and critique one another in a positive manner. Ineffective characteristics would be communication is sparing, little self-disclosure, self-serving roles, like somebody would be the dominator, they would be a blocker, or they would be an aggressor. And then you have decision making. So effective characteristics would be problems can be identified, an appropriate method of decision making can be used, and a decision is implemented and followed through, and group commitment to the decision is high. So everybody's on board. We all identified what the appropriate method would be and what the appropriate decision would be, and we went forward with it. Ineffective characteristics would be problems are allowed to build without resolution. Little responsibility is shown for problem solving, and the group commitment to the decision is very low. We have responsibility, so members feel a strong sense of responsibility for group outcomes. Leadership is effective style of leadership meets the desired aims that the group has. Ineffective leadership styles are used. That would be ineffective characteristics. And then lastly, for power, effective characteristics would be that sources of power are recognized and used appropriately. The needs or interests of those with little power are considered. And then ineffective characteristics would be power is used and abused to fix immediate problems like attention to the needs of powerless. So those were some good examples. Factors that influence communication. So we talked a little while ago about developmental level. So the rate of language development is directly correlated with a patient's neurological competence and then their cognitive development. It's helpful to understand the process of language development. and the stages of intellectual and psychosocial development. It's going to be able to help you communicate effectively with not only your patients, but their family members of all age ranges, from young to old. Gender, so men and women often have different communication styles, and they may give different interpretations to the same conversation. You have socio-cultural differences, so you need to recognize ways in which culture, a person's economic condition, and their overall lifestyle can influence a patient's preferred model of communicating. This is going to help you understand what the patient understands. So maybe they come from a background at home where they don't have a lot of good communicating. Maybe there's no communicating. Maybe they come from a very controlling situation where they're not allowed to communicate. You have to take those things into consideration because they might not be good communicators. So you want to try and figure out what the patient has experienced, what their background is, what their socio-cultural differences are, and that way you can better pick a communication style that will help them to learn. You have roles and responsibilities. So a person's occupation might give the nurse a general supposition of the person's abilities, their talents, their interests, and their economic status. Stereotyping a person according to their occupation, however, can be very misleading, and this should be avoided. So an example would be, sometimes nurses take care of other healthcare professionals, and you just assume that because they're a doctor or because they're a nurse, that they completely understand everything about their condition and they need little nursing assistance or help or teaching. And that couldn't be the furthest from the truth. Most doctors have specialties, so they work in one aspect and they just know about that one thing. Nurses are the same way. So if you work on a med-surg floor, you don't understand about the ICU and the different drips and putting people to sleep and intubation and things like that. So there's always room to educate. So you don't want to assume that patients know things. You have space and territoriality, so people are most comfortable in areas that they consider their own. The hospital room is not their own. They don't feel comfortable. We know ourselves that we feel great relief when we come home. We take off our shoes, we take our scrubs off, we put on our pajamas, we get to relax. That gives us a good feeling. The actual physical difference between the nurse and the patient during the interaction is also important. So we call that proximatics, which is very simple. It's just the study of distance zones between people during communication. Each person has a sense of how much personal or private space they need and what distance is comfortable or optimum for them. We're going to talk more about that in a minute. I'm going to flip over and I will show you that slide. We have physical, mental, and emotional state. So the degree to which people are physically comfortable and mentally and emotionally free, that allows them to be able to gauge in interactions with you and other people, also influences their communication. So if a patient is in excruciating pain because they just had surgery, you would not want to pick that time to come in to talk about educating them on a new medication. That would not be an opportunistic time. If the patient has a full bladder, they have to go to the bathroom, or they have a dull headache, or they're having crushing chest pain. Maybe they are being anxious because they're pending, the results of a biopsy and they're afraid that it's going to be cancer, or there's a concern, they're worrying about what's happening at home because they're in the hospital. Can they pay all their bills? Who's taking care of their animals? And fear can negatively influence proper communication. So you want to take all these things into consideration. And sometimes people will, sometimes you will go into a room. I remember one time I was taking care of a patient and he was an older man and I had gotten a report and he had been there for a couple of days, and everyone that I got report from told me, I talked to the nurse and then I talked to the charge nurse and then I got report from my tech, and all of them were like, I'm so sorry you have to take care of this guy today. He's a real ass. He's been mean to everybody. You can't satisfy him. He's just ignorant and hateful and mean. You're going to have a terrible day with him. So I learned early in nursing that I cannot always believe what I get in report, because usually they tell me I have a terrible patient and for some reason they turn out to be great and I love them and we have a great relationship. So I try to take what I get in report with a grain of salt and just make my own opinion. But I was a little scared because so many people told me how horrible he was. And then I noticed as I went throughout the day, he wouldn't smile. He was very, he had a flat affect. He didn't want to make eye contact with me. He ordered me around and told me, do this, get this, do that, move my bowl here, do this, do that. And I let him do that for the first part of the day. And I was still very kind to him and very nice. And then in the afternoon, I asked him if he wanted to order lunch and he yelled at me and he said, I don't want anything to eat. Don't you understand that? Why do you keep asking me questions? And I said, I can't remember his name. I said, we'll use Mr. Jones. Mr. Jones, I can tell that you really seem agitated for some reason today. I said, I've tried a couple times to comfort you and do things that I think would make you feel better, but I can still see that something's not right. Is there anything I can do for you? Is there anything you want to talk about? And he looked at me and he had tears in his eyes and he said, you know, you're the only person in 5 days that has bothered to even ask me once what is wrong with me. So there was something wrong with him. He wanted someone to ask him what was wrong with him, clearly, because he wanted to talk about it, but he didn't have the communication skills to be able to do that. Instead, it just made him angrier and more hateful, and then in turn, he took it out on the staff. So I said, I'm really sorry that that happened to you. I'm sorry that no one took the time to ask you what was bothering you. I said, but I can't change what happened before me. I said, but I'm here now and I have a couple minutes. Do you want to talk? And he said, I do. He's like, I am so scared. And I said, it's not a good feeling to be scared. I'm sorry you're feeling like that. Tell me why you're scared. And he said, I can't breathe and I feel like I'm going to die. My chest hurts every day and I don't think I'm going to get home to my wife. So imagine what he was feeling like. That's a terrible feeling to feel like you're dying. It's a terrible feeling to feel like you can't breathe. And he really needed someone to communicate with him, but he didn't have the communication skills to just say, do you have a minute? Can you talk to me? I'm really upset about this. So this is what I mean about how was he raised? What was, what's his culture? What happened in his lifestyle that taught him how to communicate? Not everybody communicates the same. So, let's see, I'm not sure exactly where I was going with that. I just went off on a tangent, but so we were talking about physical, mental, and emotional state. So you want to make sure that when you're talking to your patient, they're in a right state of mind before you educate them or try to communicate with them, okay? Oh, we were talking about fear, how it can negatively influence communication. So that was my example of that. So then we have values, which is communication is influenced by the way people value themselves, one another, and then the purpose of any human interaction. Some people don't believe the communication is key to anything. They don't care. They don't like to talk. They don't think it does anything for them. Nurses who believe that teaching is an important aspect of nursing and who value empowering their patients will communicate this to their patients. And conversely, a nurse who believes that teaching is an unimportant chore and it's likely to be, he or she is unlikely to be an effective teacher because they don't see the importance of it. A patient's motivation or lack of motivation to develop new self-care behaviors cannot help but influence the nurse-patient communication. So it's a two-way street. And lastly, you have your environment. So communication happens best when the environment facilitates an easy exchange of needed information. The environment most conducive to communication is one that is calm and non-threatening. The goal is to minimize distractions and ensure privacy. So you want to make sure if you're going to have a conversation with your patient that that they're not eating their breakfast, that they're not working with PT, that they're not in pain, all those things that we talked about before. We want to make sure that their environment is conducive for that good communication exchange between you and them. All right, so we talked a little bit about, actually it's not on your slide. Let me see if I can copy this and put it, I want to see if I can put it here. Let me see. I want you guys to be able to see this, and I'm not sure why it's not on yours. Let's put it here. There we go. Okay, so wait a minute, let me try this one. This is better. Okay, so this is what I was talking about the 4 distance zones. So this is what the patients, how the patients feel. Their this is how they feel about patients being close to them. They're being conscious of their space and their territory. It's called proximetics, which is the study of distance zones between people during communication. And each of us have our own sense of what we think is personal or private space and what we need when we're communicating with people. So if you're within 0 to 18 inches of someone, that is a very intimate zone. Things that you would be doing in that intimate zone would be assessing your patients, listening to those heartbeats, giving a bed bath, things like that. Then just a regular personal zone is, considered 18 to 4 feet. That's pretty far away from the patient, but you're still in their personal zone. And then you have a social zone, which is 4 to 12 feet. We know all about social distancing, right? 6 feet, that would fall in this category. So you could be in the room just having a conversation, sitting in a chair. And then you have your public zone, which is 12 to 25 feet. So that's proximetics. We will answer that in class. So now we have, come on. Components of communication. So communication is an exchange of information that we said earlier. We can use words, including spoken and written. Verbal communication is going to depend on a patient's language or a prescribed way of using words so that people can share this information effectively. A patient's use of written and spoken language forms reveal aspects of the person's intellectual development, their educational level, and their geographic and cultural origins. So we have to listen to how people are communicating with us and make changes based upon what we're seeing. So if we're speaking to a patient that speaks English and Spanish, but English is their second language, they may not be communicating very well with English. Maybe they just know limited English. So you would want to make the attempt to get that interpreter in the room so that they could feel more comfortable and have a better understanding of what you're saying and what he wants to say to you. Because if patients feel like they can't get their point across or they're frustrated, then they shut down, and that ends all signs of communication. I've seen patients that come in that are sitting in their rooms, and doctors will come in for round, and the doctor will just start off on a tangent saying the biggest words that maybe I never even heard of. And the patients have no idea what they're talking about. And they're literally just sitting there nodding their head, yes, yes, yes. Do I understand? Yep, I understand. The doctor will say, do you have any questions? The patient will say, nope. The doctor will leave the room, and I'll say, Mrs. Jones, did you have any questions? And they'll say, I didn't understand a word he said. So when patients feel like they're not going, that they're lost, no one's understanding them, or they can't understand you, they just completely shut down. Nurses use verbal communication extensively when we provide patient care, including all the verbal interactions that we have with the patient. We have verbal interactions with the family. We're giving oral reports to other nurses at the change of shift. We're giving report to other healthcare providers like PT and OT. If speech is going to come see them, we're going to give them a rundown. We're going to give the tech report of what our patients' needs are for the day. Other healthcare providers, the doctor, we're going to be developing nursing care plans and then evaluating their patient progress. So verbal communication can be one way. You could just be giving information over the phone to someone. A patient may call and say, can you tell me, I'm calling to give you results on Mrs. Jones' labs today, and you just give them the lab. And then maybe it's a two-way conversation where you're going to give some information and they're going to give information, and then it can also be multi-directional. So vocal communication is the sound and tone of your voice. Habits can reduce your effectiveness as a speaker. Clear speaking is a learned skill. You have to study the way you speak. You want to face the person you're addressing. You want to use words that you're comfortable with saying. Your words, your tone, your rhythm, your inflection, and your posture all work together. All these things contribute to the way that your patients are going to see you, the way they're going to perceive you, and how your communication is going to go. Like we said, the speaking is a learned skilled, and you have to practice the way that you speak. It's hard sometimes to face the person that you're addressing, especially if you don't have confidence in yourself, but doing that expresses confidence. It makes the patient have faith in you and believe what you're saying. And then you should always use words that you're comfortable with. We always say, talk like a nurse, talk like a nurse. Well, we want you to talk like a nurse. We want you to understand what you're saying. And if you're saying things that you don't understand, then we want you to use language that you're comfortable with. So then we have more components of communication, which is nonverbal. So nonverbal communication is signs, signals, and symbols. Okay, so this could be someone who does sign language. This could be writing things down on a piece of paper. Some patients who have had tracheostomies and that don't have speaking valves, their only way of communication is for them to try and use their hands somehow to express something, or they write things down on paper, or they have a board where they can circle things to point out to you. This includes your body language. Remember, we gave the example a few slides back about the patient who said he was fine, but his posture and the way he acted said otherwise. Your appearance, your posture, your gait, your first impression is very, very important, both for you and the patient, and then the patient, the way they perceive you. So facial expression, eye contact, gestures. Eye contact typically conveys interest and respect. So if you walk into the room in the morning and you say, Mrs. Jones, I'm here today, I'm going to give you your medications. How do you like to take your medications? If you don't look at your patient, if you're just running around the room and you're doing stuff on your cow or your computer on wheels is what I call it. It's called a cow. If you're tidying up the room and you're not looking at your patient might feel like you're not really taking the time. You don't really care about them. If I come into the room and I bring my cow next to the bed and I stand there next to the bed and I put my hand on her arm and I say, good morning, Mrs. Jones. I'm Trish. I'm going to be your nurse today. How are you feeling? I make time to look at her, to see how she's doing, okay? Making that eye contact makes her feel like I care about her. It makes her feel like I value her, that I'm not just here to get a job done, that I really care about her as a person. I genuinely want to know how she is. I'm also taking that opportunity to look at my patient. How is she breathing? Does she have any open sores on her face? How is her face? Is it symmetrical? How is her, is her lips blue? Are her respirations appropriate? I'm looking at her skin while I'm talking to her. So there's valuable information being exchanged just by making that eye contact. Then we want to, other nonverbal communication can be sounds. So your patient can be crying or moaning, okay? That can have multiple meanings, especially when there's other nonverbal communication. So if your patient is curled up in bed and they're crying and they're moaning, you can ask them what's wrong. Maybe they're having pain. Maybe they're just depressed. It could be a number of things. For patients who are developmentally delayed and they're not nonverbal, it can kind of be hard to figure out what's wrong based upon the sounds that they're making. But usually if they are making some kind of uncomfortable sound, there is something going on. They're uncomfortable. They have to use the bathroom. They're in pain. And then territoriality. So that is lack of awareness of your territory and your right to your personal space, okay? And it can make clients perceive a threat, or it can cause them to react defensively. So you always want to be conscious of your patient's space, just like you would want someone to be conscious of yours. So we have electronic communication. So social media is huge. We know, we've heard about it. Most of us are on it. The American Association, the American Nurses Association, the ANA, and the National Council of State Boards of Nursing, NCSBN, have issued guidelines for nurses regarding the use of social media. They agree that professional boundaries must be followed in the social media environment. In 2010, the National Council and State Boards of Nursing, yep, in 2010, a majority of them stated that they had received complaints regarding nurses who violated patient privacy by providing information or photos of patients on social media. The response from the Board of Nursing varied from just a letter of concern or all the way up to a suspension of the nurse's license. So they do take this extremely serious. You never want to take a picture of anything going on in your patient's room. You don't ever want to take a picture of any of the information that can be considered private through HIPAA. You don't want to take a picture of your patients. You don't want to take pictures of their wounds. You don't want to think that something's really gross and say, oh, let me take a picture of this and then come home and show it to your family members. And you definitely don't ever want to post it on social media. Emails and text messages, the risk for violating patient privacy and confidentiality exists anytime a message is sent electronically. And then healthcare agencies usually have secure measures in place to safeguard email and text communications. So just recently at the facility that I work for, which is GBMC, our system was compromised. I'm sure you guys heard about it on the news. They had an attack, and all of our systems were compromised. We haven't had computer systems for a month now. And we have had to use our own personal cell phones to communicate because it affected everything. We didn't have any online access. We didn't have any phones in the hospital, so we had to use our own cell phones to communicate with other doctors. And there was a problem where one of the nurses sent the doctor a message via a text message, and included the patient's name, her entire name, which we normally do when we are using our cell phones, our other work-related cell phones, because they're protected and no one supposedly can get into them and obtain any information. But this is not something you would want to do on your personal cell phone. So you always just want to be conscious of that. You would just maybe want to list a room number, or maybe the first initial and the first initial of the last name. You wouldn't want to list that whole name. So nurses cannot transmit or place online individual identifiable patient information. So this is what the ANA says. The ANA says that they can't transmit or place online individual information, that they must observe ethically prescribed professional patient-nurse boundaries. The nurses should understand that patients, colleagues, institutions, and employees may view the postings. So other patients can find out if you've posted something. Maybe you have a patient maybe you're taking care of a patient and you both have a mutual friend and you don't know about it. And this patient is particularly angry and you had a really rough time with him today. And then you go home after work and you say, I had the worst shift ever. I had the biggest a-hole for a patient who was disgusting and ignorant. He didn't want to bathe, blah, 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 whatever you're going to say about the patient. And then you have a mutual friend who knows that you work at the hospital and knows that his friend is in the hospital, and he says, hey, did you happen to have this nurse today? She was bragging, she was talking about how much she hated her patient. Other colleagues can see what you write, the institution can see what you write, and you don't want your employer to see, negative things like that. It impacts you and it impacts them also. Nurses should take advantage of privacy settings and seek to separate personal and professional information online. And nurses should bring content that could harm a patient's privacy rights or welfare to the attention of appropriate authorities. Nurses should also participate in developing institutional policies that govern online conduct, especially in the day and age that we're living in now. I think that is extremely important. And I know that GBMC has a policy to make sure that we're doing the right thing by social media. So the process of communicating, we're going to talk a little bit about what that looks like. So sending the message, that's exactly what it is. It's information that's communicated from or to you. Think about your electronic messages to avoid misunderstandings and misinterpretations. So we all know that sometimes you send a message that means one thing and the person on the other end thinks that it's something else. It's the biggest way to have a miscommunication is to send something in a text messages, because there's no way to identify how the person meant it or how they said it, because it's through a text message. And then you want to use the method that's most appropriate for your situation. When you're speaking to your patient, you want to use correct vocabulary, grammar, medical terminology, and the correct abbreviations. So you want to use medical terminology, nursing terminology, but you want to make sure that your patient is at the appropriate level, so that they're going to be understanding what message you're trying to send them. You don't want it to be over their head in terminology that they've never heard before. You want to use the correct grammar. We said that. You want to make sure you're speaking clearly. You want to use good judgment when you're talking. You want to express confidence, even if you're not confident in what you're talking about. You want to walk the walk. And you want to listen to your patients without interrupting. Listening is one of the best things that you can do for your patients. People need to be heard. People, even if you can't do anything to solve their problem, just listening to them, it makes them feel better. It shows them that you care. I can't tell you how many times so many times that I just can't even count how many times a patient has said, "Thank you for listening to me," or "You're a good listener," or I know you don't have to listen to me. It's not part of your job. You have so many other people to take care of, but thank you. Well, listening is part of our job. It is an extremely important job to be able to show up and be present with our patients and really listen to them. And it's a good feeling to be able to do something for someone that can't do anything back for you. So really listening without interruption, that's important. You want to use accurate descriptions when you're speaking. If you don't know something, it's okay not to know something. You don't know everything. There's things that I don't know that my patients will ask me, and I'll say, "You know what? I really don't know. Let's look it up." You always have plenty of things at your in your computer that you can use, and you have different sites that you can go to, or you can even ask other nurses or doctors. If you don't know the answer, you just tell them, "I'm not sure, I'll get back to you on that." And then you want to follow guidelines to improve the quality of the message. So if you've gotten any feedback that tells you, you should do this or that, then you can work on that. You have writing, which is a significant way of communicating information in healthcare. So we chart every day on our patients. So charting as a direct influence on patient care. You want to think about things that you're charting. So when you chart, you want to give the facts. You never want to include your opinion. So if Mr. Jones has called you 4 times in the past 2 hours for pain medicine, and you gave him medicine an hour ago, and he still says his pain is a 10 out of 10, it's not working, your note may sound something like, Mr. Jones received 650 milligrams of Tylenol at 11 a.m. The patient has since called out 2 times stating that his pain is still a 10 out of 10. This RN contacted the doctor regarding a higher dose of pain medicine for which I have received no new orders. The patient appears to be comfortable. He's sitting in his bed resting. His perceived pain is not appropriate, or I perceive that his pain is not real. So those are things you would not want to put in the chart. You only want to give the facts, because our opinions don't matter when it comes to putting things in the chart. And then you only want to use approved abbreviations. So this is something we're going to talk about a little bit more, especially in your pharmacology course. Let me find what page your approved abbreviations are on. Give me just a second. Okay, so in your Taylor book, starting on page 459, which is in chapter 19, and then it continues, gives you some more examples all the way through like 462. It goes into some medications on that page, but there are a list of your of common abbreviations and symbols used by healthcare professionals. So you want to make sure that you're using abbreviations that are appropriate and recognized by all healthcare professionals. You just don't want to make up your own abbreviations, okay? So some of the things that you might document are, if a patient has a sexually transmitted disease, you're gonna abbreviate that as STD. If they have an upper respiratory infection, you might document it as URI. If the patient is going to have the head of their bed elevated, you're going to put that as HOB. If you're doing strict eyes and nose, you're going to see that as written I, N, the N sign, and then O. Sometimes we talk about a nasogastric tube. You would see that abbreviation as NG. So you just want to make sure that you're using abbreviations that are appropriate, that other people can go behind you and understand. That's really important, because you don't want anybody else to have to come behind you and say, well, what did Trish mean when she was working today? I have no idea what this means. It can cause harm to the patient, and that's definitely not something that we want. So the process of communicating, we're going to talk about receiving the message. So reading is an important vehicle for conveying information and ideas. It's an essentials of effective reading are how fast you can read and how well do you understand what you read. You want to observe how you read. You want to change poor reading habits. Will make you learn things easier if you can change your reading habits. And then building a good vocabulary is an excellent way to improve comprehensive. So you have your common language and your medical terms. So what can you do to build a good vocabulary? Well, you can make flashcards. You can practice at home. You can make a list of common languages that you hear. You could even make a list of this abbreviations and symbols and take it with you when you go into the clinical setting or when you're working. It's good to have these lists, and it shows that you care enough to learn and that you want to make sure that you always have the right information around so that you can speak appropriately to your patients. And we have listening. Like I said before, this is so important. So the receiver's role is to listen. Hearing and listening are two distinct activities. So hearing is biophysical. Listening is an actual active process. I can hear what you're saying and still run around the room and do 100 different things. Listening and being present for your patient, that's an active process. Really taking the time to focus on them and listen to really hear what they have to say. And effective listening skills are necessary and a major part of your expertise as a nurse. A good listener always gains the confidence of the speaker. So if you really listen, if you're going to hear me say this over and over again throughout the next year, if you really listen to your patients, if you're really present with them, they're going to respect you. They're going to value your opinion. They're going to trust you. And if they trust you, then they're more apt to have a say in their care and follow the recommendations that you make for them. So it's extremely important. All right, the process of communicating. So egocentricity conflicts with the needs for nurses to be exceptional listeners. There are 3 steps to good listening. The first one is to focus your attention on the speaker and really hear what they're being said. So focus your attention on that. If you're listening to your patients, don't be ripping up your meds. Don't be scanning your meds. Don't be tidying up around the room. Don't be cutting up your patient's breakfast. Really focus your attention on listening to them. You want to listen to what they're saying and interpret what they're trying to get you to understand. And then after you think you understand what they're saying, you restate what you thought you heard. Being a good listener means being receptive and open, but not playing the role of the advisor. So you don't have to advise the patient to do something every time they talk to you. You can just listen and not even say anything. That's what people want sometimes, and that's okay to do. You just listen, you put your hand on their shoulder, you put your hand on their leg, you hold their hand. Sometimes you just don't have to say anything. So if you're talking to Mrs. Jones and she tells you that she is scared because she hasn't seen her family and her friends, and she wants to have her surgery, but she's afraid that she's going to die during her surgery, and she doesn't have any family or friends with her in the hospital. This is what she's telling me. So I actively listen to her. I have interpreted that that's what I feel like she's saying, and then I reinstate it. And I say, okay, Mrs. Jones, I'm really sorry you're feeling like that. It sounds to me from what you've told me that you do want to have the surgery, that you know you need to have your hip replaced. that it's going to be beneficial for you, but you have valid concerns that you might not wake up from your surgery and that you would probably feel better if you had friends and family here. Is that right? And then Mrs. Jones is going to be able to say, yes, that's exactly what I'm trying to say. So you always want to restate to the patient what you thought you heard. So the process of communication, you want to listen without interpreting. Okay, you don't always have to interpret. Sometimes you just have to listen. You want to ask questions that show interest related to what the patient, to what's being said. You want to be courteous, interested, and non-judgmental. Even if they're talking about things that you don't have any interest in or things that you don't particularly believe in yourself, you still be courteous, show interest, and don't be non-judgmental. And then ineffective communication skills can lead to errors in patient care. Not listening to your patients, not really being focused when you're in the room, not hearing what they have to say. Those are all things that can have a negative effect on the care that you give to the patients. So these vignettes, we will take care of these when we have our live lecture. So pay close attention to what the patients say and how they say it. Avoid frivolous conversations. Respect your patients and address them as they prefer. So you want to be honest and you want to develop trust. You want to ask questions that require more than a yes or no, and you want to restate what you thought you heard. So when you're listening to your patients and you're talking to them, not every patients don't want to be called honey or hun or love bug or doodle pins or whatever other kind of name that you have for him. And I'm the worst at that because I always come up with the craziest names. Like Nani or sugar pie, apple dumpling, whatever. I don't know why. It's not that I want to be disrespectful, but I always feel the need to say those crazy words and say them to patients. And some people are okay with it, but it's not respectful. It's not how we should address them, and we should always ask them. So what I do when I go in the room is I always have their name there, and I address them by Mr. or Mrs. And I'll say, good morning, Mr. Edwards. I'm Trish. I'm going to be your nurse today. And then I'll start updating the board and I'll say, what do you like to be called? And then they usually tell me I like to be called Jim or Joe Bob or whatever they prefer. And then that's what I write on the board. When you do this and you respect them, it helps them to develop trust in you. And if you're honest with them, it also helps to develop trust. So sometimes a good example of that is I get overwhelmed as a nurse, and I am not always good about delegating to my techs. I don't know why, I'm just not, because I know what it's like to be a tech, and I know that techs are very, very, very busy, and CNAs too, and they have more patients than me. Even though we both have different job duties, I still have a hard time delegating sometimes. So if I still have 4 patients to see that need meds, and my patient says, can you put me on the bedpan or can you get me a glass of water? I'll do it instead of delegating it because I know that they're busy, or if they're not right there, I don't want to interrupt them. But anyway, sometimes I will forget to bring a glass of water back. I'll give them their meds and I'll say, okay, I'm going to go grab you a glass of water and then I'll be right back. Well, in the meantime, something happens with my other patient. They call out and say, I'm dizzy, I can't breathe, whatever, and I have to rush to them. Well, then I totally forget that I had told that patient in the other room that I would give them water. And then as I come out of the room and I'm walking by the patient, I see their room and I say, oh my God, I forgot to grab them water. How could I have forgotten? I run, I grab the water, I come back, and the first thing I say is, Mr. Edwards, here's your glass of water. I completely forgot to do it. I had the best of intentions. I left the room as soon as I went to leave your room to get that water. I had an issue with another patient in another room, and then I honestly just never thought about it again. I'm so sorry. I wish you would have called out and it would have reminded me. It's okay if you forget something, and it's okay to make a mistake. But when you're honest with your patients, they trust you because they know that you're honest. And then ask questions that require more than a yes or a no answer. So we're going to talk more about that, about using that open-ended questions that require your patients to give you a little bit more. Instead of saying, are you ready for breakfast? And they say yes or no. And did you order? Yes or no. You can say, are you hungry right now? What kind of things do you like to have for breakfast? When do you usually eat breakfast, Mr. Edwards? Do you eat early in the morning? Do you eat closer to lunch? Do you eat breakfast at all? So ask those open-ended questions. We're going to talk more about that. So when you're communicating with your patients, you want to use clarifying phrases. You want to have a purpose to your communication. You just don't want to come in and ramble on about things that don't make any sense. So you want to come in and know exactly what you're going to communicate with your patient and why you're going to communicate it. You want to maintain confidentiality. So if you're talking about HIPAA sensitive things, personal patient information, you want to make sure that the door is shut and that nobody's outside the door listening. You want to make sure that there aren't other family members in the room. And if there are, you want to make sure that you get the patient's permission to be able to talk about things. You want to write down any important facts and instructions. So patients get overwhelmed very easy in the hospital because they have many different people from many different, that have different jobs in the hospital coming into their rooms. They're seeing the nurse. They're seeing, maybe they're going to see speech pathology. Maybe they are going to see infectious disease. They're going to have PT and OT. And it gets very confusing when they see a variety of different people. And it's too much information for them to be able to understand. And they get overwhelmed, especially if they're really sick. So if there's important things that you want them to remember, it's okay. You can write it on the board with your pen. You can write it on a piece of paper, leave it at their bedside. It's okay to write things down. I do it all the time when I'm going over discharge instructions, because our discharge instructions are sometimes like 12 pages, and I want the patients to be able to navigate to the important information. So I highlight it, I put stars by it so that I know when they get home, they're going to be able to find that information. You want to show by nonverbal communication that you have time and you want to listen. So how can we show our patient, not using any words, that we have time for them and we want to listen? A good example is what I told you earlier. When you come in the room, you stand at the patient's bedside and you just be present and you just talk to them and you make eye contact with them and you smile at them. Those are the ways that patients think that you really care about them and you really have the time to be present and listen to what they have to say. And patients will never, ever forget the way you made them feel, ever. So communicating empathy, this is also it's very, very, very important, I feel like. Nursing requires that you provide emotional support, encouragement, and understanding. You want to learn to provide compassionate care without emotionally exhausting yourself. Conservation of a physical and emotional energy helps avoid exhaustion and loss of interest in your job. And empathy is intellectually, but no emotion identifying with feelings, thoughts, or attitudes of another person. So it is possible for you to empathize someone, but not have sympathy and not get overwhelmed. And you can learn to do this. It does take practice, I feel like. And it's hard not to get emotionally involved in your patients. There's a fine line, and it takes a lot of years of practice, I feel like, but it is possible. So you want to empathize with your patients. People like to know that you understand what's going on with them. So if Mrs. Edwards says to you, I'm really scared. I think I'm going to die. I wish my family member was here. I don't want to have this surgery. I'm really scared. So you don't feel that way. You're not scared, but you can empathize with the fact that she feels like this. So what you would say is, Mrs. Edwards, I'm really sorry that you are experiencing this. This must be very hard for you to be so scared and to have a surgery without any of your family members here. I'm so sorry you have to go through that. That's empathy. You're recognizing their problem and you're offering them a little bit of support. That kind of stuff goes a long way with patients. Sympathy goes beyond empathy because it involves an emotional response from you, okay, as a nurse. Sympathy is the expression of sorrow for someone's situation involving compassion and kindness. Sympathy shifts the emphasis from the patient to the nurse as the nurse shares feelings and personal concerns, and then she projects them onto the patient. Employing sympathy rather than empathy limits your ability as the nurse to be able to focus objectively on your patient's needs. An empathetic nurse will always be sensitive to the patient's feelings and problems, but they still remain objective enough to help the patient work to attain positive outcomes. You can establish healthy helping relationships without appearing cold or stern by retaining the quality of empathy. Family members. So a good example is maybe you have family members that are calling multiple times throughout your shift to check on Miss Edwards. Miss Edwards has 5 daughters and 3 sons, and they're all calling, and then the grandchildren are calling. So you're getting 12 phone calls a day because they're really worried about your mother, but you have 5 patients to take care of. They're all acutely ill, and you've been running around all day. It's 3 o'clock in the afternoon. You haven't peed or you haven't had lunch, and the last thing that you want is another phone call. But you understand that the patient and the family are missing their loved one, and they're very scared about their loved one, and they want to make sure that they're in good hands and that they're getting good care and that they're going to be okay. So you can empathize with their family members. You understand where they're coming from, even though it can be frustrating. So that's a good example of that. And then when the patient and the family sense that you have an idea of what they're experiencing, when you empathize with them and that you're committed to helping them, the basis is then set for that trusting therapeutic relationship between both of you because they feel like they can trust you. So sympathy does go beyond empathy. We said that it involves emotional response. Being empathetic helps you keep distance so you can still think and act in your patient's best interest. And then being empathetic helps to conserve your emotional energy. So there are blocks to effective communication. So you want to avoid using techniques that prevent knowing what and how the patient feels and thinks. You never want to say, yeah, you don't ever want to come out and say, I know what you're thinking. Oh, I know how that must be. Or you don't want to assume that a patient feels or thinks a certain way. You always want that to come from the patient. Even if you're thinking it, you want to keep it to yourself. So there are nonverbal barriers such as body movements. Maybe you're rushing around the room, you're standing in the corner with your arms crossed, you don't have a comfortable, welcoming stance, you're not making eye contact with the patient, you're changing the subject when they're talking to you about how much they miss their late husband and how things haven't been the same. And in the same breath, you're saying, how do you want to take your medicine today? Where do you want to have your insulin? Giving false reassurance to your patients, that's something you never want to do. If your patient says, I'm really scared, am I going to die? You don't want to say, no, you're not, because that's giving false reassurance. You don't know. It sounds terrible not to say that, and you want to say, no, you're not going to. It seems like the right thing to say, but that is giving the patient false reassurance. So instead, you want to follow up with something like, I know you must be scared, that you know that there's a possibility that something could happen with every surgery, but you are in good hands. The doctor has talked to you about what the risks are, and you have agreed that the benefits of this surgery outweigh the risks. And do you pray? Do you have a higher power? It would make you feel better if you prayed, but you can't just lie and say, you're going to be okay. Don't worry, you're not going to die, because we don't know that she's not going to die. So stereotyped responses, you want to make sure that you're not saying things like, everything's going to be fine, Mrs. Edwards. Stop worrying. I don't know why you're worrying. Don't worry. You're going to be fine in another day or two. Before you know it, the surgery is going to be over. You're going to be fine. Your doctor knows best. Just listen to what he says, or cheer up. Tomorrow's a better day. You don't have to be so depressed. It's going to be okay. Those are what we call stereotype responses. We don't want to do that. We don't want to have any personal biases. So we want to examine our own thoughts on different things and make sure that we're not portraying our biases onto our patient. We talked about asking those yes or no questions. So you want questions that can be answered simply by saying yes or no tend to cut off discussions, even when the person might wish to continue. So you want to consider using um, like the following question. This is a good example. So you say to the patient, did you have a good day? Do you want to get out of bed? What are your goals for the day? Where do you like to take your insulin? You want to ask questions that are going to help that are going to enable your patient to elaborate more and give you more information. You don't want to have any belittling feelings or expressing disapproval. So if some patients say, if I want to go in and I want to give them a subcutaneous injection in their belly of heparin, we tend to give that prophylactically for some of our patients, because when you come in the hospital and you're not moving around, you're at risk for developing a blood clot. So we give them this prophylactic dose of a blood thinner, and it goes in their belly, and most patients don't like to have injections in their belly. So they're like, I don't need that. I'm moving around. I'm fine. You educate your patients again, and you say, well, let me just explain to you exactly what you're at risk for so that you can make an educated decision about not taking this medicine. And if the patients decide again that they don't want that injection, then you don't want to express disapproval for their decision. You have to respect their decision. So you wouldn't want to say, that's fine, but don't call me when you get a blood clot, or I told you that this could happen. You should have listened to me. So you want to make sure that you are respectful and you respect their decision. You want to minimize, you don't want to minimize their feelings. So if you have a patient that's crying because they're nervous about having surgery or they miss their family, you don't want to say, well, why are you crying? You aren't acting very grown up, are you? What would your children think if they saw you acting the way you are? You never want to do that to your patient. And then, of course, you never want to argue with the patient. That's a big no-no. So communicating with team members. So you're going to have physicians. When you're talking to your doctor about patients, you're going to want to make sure that you have all the information needed to describe a certain situation. And we talked about before, and we're going to keep on talking about it, is that SBAR, right? The SBAR, situation, background, situation, background. So you have situation, background, assessment, and then your recommendation. So you want to make sure you have all those components when you call the doctor. So if your patient is not breathing properly, or they have increased respirations, or they're having crushing chest pain, so you want to call Dr. Jones, and you want to say, hi, Dr. Jones, this is Trish. I'm caring for the patient in room 34 of 25, Mrs. Edwards. She called out to the front desk a little while ago and stated that she has some crushing chest pain. She's reporting her pain as on a scale of 10 out of 10. We did an EKG on her. We're waiting for the results. Her blood pressure is this. Her heart rate is this. She's afebrile. Her respirations are this. Her oxygen level is this. She's not complaining of a headache. You want to give all the information that you can anticipate that the doctor is going to ask for. You want to give facts and not your personal opinion unless the doctor asks. So you don't want to say, Mrs. Jones has crushing chest pain, but I think she's just pretending because she needs more pain medicine. Or I personally think she's having a heart attack. What are you going to do? Are you going to order this? Are you going to order that? You just give the facts and you let the doctor make the decision. You have to use tact to clarify written and verbal communication. When you're communicating with your supervisors, you want to, your supervisor is legally liable for your actions. So you want to make sure that you're communicating with them just like you would for your physicians. Whenever you're communicating with them, make sure you have all the information that you need, and all the rules for good communication apply to this relationship. All the rules for communication, in my opinion, apply to all the relationships with people, whether it's doctors, team members, patients, family members, whoever it is. You always want to have that good communication. And your supervisors are no different than the other people that you communicate with. So other members of the nursing team, you want to have good communication skills because this reduces misunderstandings and conflicts. Good communication is necessary in planning and implementing nursing care. So you want to make sure you're communicating with other members of the healthcare team. Maybe the vascular access team needs to come and put an IV in your patient and you're communicating with that nurse about when they can come, and that nurse wants to make sure that the patient is in bed, not in their chair. So you want to make sure that you're communicating the proper information and say, yes, Mrs. Jones is in her chair right now, but I will have her in the bed. When do you plan on coming? And you want to make sure that that happens. So you want to facilitate good care by making sure that you have good communication. You want to maintain a professional attitude at all times when you're communicating with patients, family members, and other members of the healthcare team. You want to show respect for the opinion of others, whether it's your opinion and you share that opinion or not. You want to show respect for it. And then if you offend someone, even if you don't think you do, then you want to apologize. Because if a patient or anyone says that you made them feel a certain way, then you did, whether you meant to do it or not. So you need to recognize it and own it and then apologize. So communicating with culturally diverse people. So you want to avoid confusing or offending another person. Sometimes this happens and you don't even realize it. In some cultures, it's disrespectful to make eye contact. In some cultures, it's disrespectful not to make eye contact. We don't know everything about every culture, and we just don't know. And sometimes our patients teach us, and it's okay if we did something wrong or we didn't recognize it. We learn from it, we apologize for it, and then we change our the way that we communicate with them in the future. And then communicating with culturally diverse people is a chance to learn about other cultures and people. You're going to care for a lot of different cultures and a lot of different people, and there is a lot to learn. And it's very interesting, and you grow as a person when you learn about other people's culture. So having a cultural competence, a client's language proficiency should be evaluated upon admission to a healthcare facility, and interpreting services should be available to facilitate any communication and improve the quality of care. One example of that would be a language line. So when I get patients to my floor and I admit them and they're from a different culture and they don't speak English, as soon as they get on the floor, before I go in the room, I get the blue phone, and it has two handsets on it, one for me and one for the patient. I go in the room and I hand him the one handset, and then I take the other handset and I call the language line, and I get a representative on the line, and I tell them the language that my patient speaks. And then they start speaking to the patient in that language. And then I ask my questions, she relays it to the patient, and then she translates it and then tells me what the patient's saying. So that's what we call the language line. And I make sure I have that ready before I even go into the patient's room, so that way I can make sure that I'm communicating effectively with my patient. Communicating with non-English speaking people, you want to use information that's printed in other languages. So if you are going to print off some education about some side effects related to a new medication that they're taking, you're going to want to make sure that it's printed in the language that they speak so that they can read it and understand it. You want to broadcast information on their television in different languages so that they can also enjoy TV while they're in their room. You want to use interpreters. You want to know your interpreter's education level, and you want to watch for nonverbal cues. Almost every hospital has some type of language line or interpreter. They have to have it. It's just a matter of what they have in your hospital. Each facility is different. So when you are communicating without an interpreter, sometimes patients don't want an interpreter. Sometimes maybe their English is their second language and they don't speak it great, but they speak enough to get by, and they refuse to have an interpreter. I've had that happen. So when you're doing that, you want to make sure you don't shout, which sounds strange, but when you're talking to someone, I've done it so many times, when you're talking to someone that speaks a different language, for some reason you just speak loud. I don't understand why, but you're like, Mrs. Jones, can you understand me? And you're speaking loud. Well, they're not deaf. They just don't speak the same language, but it's kind of like when you're riding down the road and you're trying to find an address and you turn down the radio, like how does that even help you? But it does happen. You want to greet the person by their name. You want to give your name, right, while you're pointing at yourself. So you want to point to yourself and say, I'm Trish, my name is Trish. You can pantomime actions or procedures if you can. You can use a pre-printed list of phrases that you know that they'll be able to understand. You can determine understanding of words and other languages. And then try and use your language just to minimize it to simple words and phrases that you know that they're going to be able to understand. And some patients just even feel comfortable if their family members are in the room, or they'll allow you to get their wives or their husbands or their children on the phone. And they're more receptive to that than the interpreter. So when you're communicating with hearing impaired people, you want to make sure that you always face that person, right? You want to have face-to-face contact, because a lot of people, the majority of people who are hearing impaired, really rely on being able to read your lips. So you want to make sure that you're right in front of that person so that they can read your lips. You want to speak very slowly. You don't want to talk really fast, because then they won't be able to read your lips. You don't want to move your head or position yourself too far away from the patient. You want to repeat anything that you feel like you need to so that the patient can have clarity of what you're saying. You want to use bright lighting in the room so that they have good access to seeing your face and they can read your lips and they can see your expressions. You want to eliminate any background noise because they already have trouble hearing to begin with. So you want to take out any background noise so that they can really concentrate and try to hear what you're saying. And then you want to make use of technology to assist in communication. These patient scenarios we are going to do when we have our live lecture. When you're communicating with vision impaired people, you want to speak in a normal tone of voice. Again, they're blind or they're vision impaired. They're not deaf. So we want to speak to them normally. You want to make sure that you announce yourself when you're entering a room, because they can startle easy. They don't see you coming, so you might catch them off guard. You want to state your name and the person's name that you're talking to when you come in. And you want to continue to talk to them as you're working, because when things get quiet, for people who can see, they know what you're doing, but patients who are vision impaired, they don't know what you're doing, and that can be a little scary or alarming for them. You want to make sure this applies to patients that are vision impaired and patients that are not. You always want to say what you're going to do before you do it. It's just very respectful. You let them know what's going to happen, but it's even more scary to be vision impaired and then have somebody stick a needle in your stomach, okay? You want to make sure you tell them, Mrs. Jones, I have your heparin injection. It's going to be a small pinch in your belly, and I'm getting ready to do it. I'm going to count to 3. And then you always want to tell your patients before you touch them. So if you're going to listen to their chest and their heart with your stethoscope, you're going to say, Mrs. Jones, you're going to feel my stethoscope. If it's okay with you, I'm going to place it on both sides of your chest, the right and the left, and I'm going to listen to your heart. So that way they know completely what's going on and what to expect from you. So communicating in some special situations, you want to tell the patients what foods are on the trays and where they're located. If they can't see, that way they know what's going on. To the left is your milk, to the right is your oatmeal. You can put their utensils in their hand. You want to make sure you put needed items within reach and tell them where they are. You want to make sure that their room is free of clutter. So this not only keeps things organized, but you have to remember that this is actually their home while they're in the hospital. No matter how long it is, if it's a day, 5 days, a month, depending on how long they're there, that is their home. You want them to be as comfortable as they can be in that environment. So you want to keep their room clean and free of clutter, or take out those extra gowns and blankets they're not using. If they have a lot of skincare things and toothbrushes and deodorant and stuff like that, you can put it all in a little basket in the corner of the room. Just try and keep it tidy. Don't move furniture without telling the patients. Maybe they like it set up a certain way. And you want to make sure you use vocal tones that convey feelings that are associated with the conversation. Another patient scenario, we're going to skip that. So when you're communicating with speech impaired people, you want to be patient when you're communicating. So patients that have speech impediments take a while. Sometimes they have delayed responses. Sometimes they know what they want to say, but they can't get it out. Sometimes they have expressive aphasia, so they're needing to say one thing, but something else comes out. Sometimes they have word salad where nothing that they say at all makes sense in relation to what you're talking about. So just be patient with them. Give them the time to really relax and get their thoughts out so that you have good communication. If the person is struggling to communicate, you can recognize that and you can say, here, Mrs. Jones, maybe it'll be easier if I get you a piece of paper. Let me get you a piece of paper and pen, and then you can write down what you're trying to say. So you can give that paper, the pencil, even if they have a laptop, you can do it on a laptop. You can look at the patient as she writes the message. Don't allow any interruptions, and don't allow her to be distracted. They need to focus on communicating. That's very important, because they get overwhelmed if they feel like they can't do something in a timely manner, and it can be very frustrating. So we said that we can encourage pen-aligning thoughts, make sure that you're not shouting at the patient, take time to really determine what the patient's needs are, even if you have to be there for a couple minutes. Use picture cards to communicate basic needs, and then ask other members of the team for tips and techniques. So maybe there's a nurse working today that took care of this patient yesterday. So you can ask her, hey, what was going on with Mrs. Jones? She keeps saying this. Do you have any idea what that means? So going to other people that are familiar with the patient can really help shed a light onto what's going on with your patient. So the helping relationship, we talked about this early on in this lecture. The difference between a helping relationship and a friendship is important. Helping relationships contain many of the qualities of a social relationship. They have in common the components of care, concern, trust, and growth, but they're also very different. So when the patient's needs are met as a result of a successful helping relationship, the term helping relationship is used to refer to such relationships between nurses and patients, okay? So you were able to meet the needs of your patients. This resulted in a successful helping relationship. When a nurse and patient are involved in a helping relationship, we also can call it the nurse-patient relationship. The nurse is the helper, and then the patient is the person that's being helped. The quality of that relationship between these people is the most significant element in determining helping, how effectiveness the helping is. Of all the problems that can arise in nursing care, perhaps the most common is the failure for nurses and patients to establish a rapport and a helping trust relationship with the other person. So communication is the means to establish rapport and to create that helping trust relationship. So the helping relationship will not occur spontaneously. And as do most social relationships, it occurs for a specific purpose with a specific person. So you know that you are going to establish a helping relationship with your patient because you are their nurse for the day, okay? That's the purpose. That's the reason. You are their nurse for today. That is the person you're going to establish that relationship with. The helping relationship is characterized by unequal sharing of information. The patient shares information related to their personal health problems, and the nurse shares information in terms of her professional role. In a friendship, the information sharing is more likely to be similar in quantity and type. The helping relationship is built on the patient's needs, not on those of the helping person. In a friendship, needs of both participants are genuinely considered. The friendship might grow out of a helping relationship, but this is separate from the purposeful, time-limited interaction described as the helpful relationship. Characteristics of a helping relationship. It is considered dynamic. Both the person providing the assistance and the person being helped are active participants to the extent that each one can be. It's purposeful and it's time limited. There are specific goals that are intended to be met within a certain period. And so we say time is limited. So in a helping relationship during a 12-hour shift, your time really during that to provide care is that 7 a.m. to 7 p.m. So that's what we mean by a time limit. So you only have from 7 a.m. to 7 p.m. on your shift to help attain the goals that you set. And after that, it becomes another helpful relationship with another nurse that you give report to at the end of the day. So although both parties, the nurse and the patient, in the helping relationship have responsibilities, The person that's providing the assistance is professionally accountable for the outcomes of the relationship. So that's the nurse. We are professionally accountable for the outcomes and the means used to attain them. So helping persons should present their helping abilities as honestly and as possible, and not promise to provide more assistance than they can actually offer. So you don't want to say to your patient, I'm going to give the rest of my meds and I'm going to come back and I'm going to walk you up and down the hallway. I'm going to give you your meds. I'm going to wash your hair. I'm going to braid your hair. I'm going to help you shave. You don't want to tell them that you're going to help them do things that you can't realistically help them do because you just don't have the ability to do it in a day, okay? You have to be able to recognize what your workload is and make sure that you can be realistic, because then patients won't trust you if they don't think that you are going to come through with what you say. So that's really important. So phases of the helping relationship. We have the orientation phase, we have the working phase, and then we have the termination phase. The helping relationship, which is that nurse-patient relationship, begins between the nurse and patient during the data gathering part of the nursing process. So we talked about earlier all the components of that process that goes into gathering the important data about your patient. You and the patient meet and learn to identify each other by name, right? During that shift change, you're coming into the room. Hi, Mrs. Jones, I'm Trish. I'm going to be your name today. You put your information on the board. You give them your number. It's especially important to introduce yourself to the patient. It might even be helpful to write your name on the board, like I do that. We have a board. The date goes on it, the day, the patient's name, what they like to be called, my name and my phone number, and then I also put my text name and my text phone number. Failure to do so can result in the patient becoming confused and mistrustful because of the number of caregivers with whom most patients come in contact with. Remember, I said a little while ago, they see a lot of patients in and out of their room. And sometimes nurses don't do bedside report when they leave and when they come on to their shift. And nurses don't say goodbye to their patients, and that can be very confusing. So imagine being taken care of all day in the hospital by your favorite nurse, and then at 7 o'clock, she just leaves and she gives report to another nurse, but you don't do it in front of the patient. You don't introduce the new nurse to your patient, and you don't say goodbye to your patient. And then an hour later at 8 o'clock, in comes a new person and says, hi, I'm your nurse for today. Well, you've established this relationship with this nurse for 12 hours prior to that, and they didn't even care enough about your goals and what you want out of your care to come to the bedside and actually do that nurse handoff and that bedside report. So that can be frustrating. The roles of both people in the relationship are clarified, okay, between the patient and the nurse. An agreement or a contract about the relationship is established. The agreement is usually a simple verbal exchange related to the goals and means of achieving them, or occasionally a written document, especially if the relationship extends over a period of time. The patient is provided with an orientation to the healthcare facility, its services, admission routines, and any pertinent information the patient requires to decrease anxiety. This orientation should be identified as one of the goals in the nurse-patient helping relationship. So when my patients come to the floor and I get a new admission, we do give them a packet. It welcomes them to the floor. It has a little guide about what to expect on our units, the care that we provide. It always gives them a list of commonly used medications on our floor. And then we give them a TV guide that shows them what stations you can find different shows on. I always go over that with our patient. I orient them to their room, and then I always find out what their goals are. Well, what are your goals? Let's establish some goals. What's going on? And they're always individualized based on the patient and their reason for coming to the hospital. We will answer that. So that is the orientation phase. Now we're going to talk about the working phase. So the working phase is usually the longest phase of the helping relationship. And again, you can use the term nurse-patient relationship interchangeably if you want to. During this phase, the nurse works together with the patient to meet the patient's physical and psychosocial needs. Interaction is going to be the essence of the working phase. The nurse, as a caregiver, provides the patient with whatever assistance they need to perform the activities of their daily living. Patient interactions that occur at this time are going to be purposeful, and they are designed to ensure that achievement of healthcare goals or objectives that they happen, that you mutually agreed upon. The nursing roles of teacher and counselor are performed primarily during this phase. These roles involve moving the patient to learn and to implement health promotion activities, to facilitate the patient's ability to execute the nursing care plan and to express feelings about health problems, nursing care, and any progress or setbacks, and then any other areas of concern. Both the nurse and the client feel harmonious and connected with each other as they work cooperatively to reach common goals. It is an extremely good feeling at the end of your shift to say that you accomplished something. That doesn't happen often. Not because you're not capable of it, just because patients are acutely ill and it's really hard to fix someone in 12 hours. So the care you provide contributes to that. You don't always see it pay off. For me, the thing that I see the most is, when I have a patient who comes in and they're on a telemetry monitor because they have what we call AFib, which is an irregular heart rate. Sometimes that heart rate gets uncontrollable. It becomes very high, and it's not what we call rate controlled. So you can have an irregular heart rate. It might not be regular, but it's still within that normal rate. Well, when it comes out of that normal rate, we call it not rate controlled. So sometimes we have to give patients medicine to help control that rate. So we have them on a telemetry monitor, and we're giving those medications, and we're constantly monitoring that heart rate on the computer screen at the nurse's station. And it's always very pleasing when you have watched your patient go from an uncontrolled rate to a controlled rate. It's very rewarding as a nurse because you actually feel like you fixed them and you've done something, and we don't get that opportunity a lot. So that's like the thing that I love to see the most as a nurse. Okay, let's see, where were we? So the working phase, now we're at the termination phase, which is the last phase. So during this phase, you're going to examine goals of the helping relationship. This phase occurs when the conclusion of the initial agreement is acknowledged. So this might happen at change of shift. Like I said, just this agreement is just for your 12-hour shift. It can happen when the patient is has been healed and they're no longer needing the services of a hospital and they become discharged, or when a nurse takes a vacation or employment somewhere else. At this point, you examine when with the patient, the patient goals of the helping relationship for indications of their attainment or for evidence of progress towards meeting their goal. Sometimes they don't always meet that goal, but they are progressing in an acceptable manner towards eventually meeting their goal. If the goals and outcomes have been reached, this fact should be acknowledged. And such acknowledgement generally results in a feeling of satisfaction for the patient and the nurse. If the goals and outcomes are not reached yet, that's okay. The progress can still be acknowledged because progress is progress, and then either the patient or the nurse can make suggestions how to, for future efforts to make sure that we can meet that goal, if not in the hospital, then at home. There are emotions that are associated with the termination of a helping relationship. If the goals have been met, there is often regret about ending a satisfying relationship. So sometimes you're really happy that your patient is better and they're going home, but you really hit it off with your patient. You guys just really meshed well together. You got along together. You know, some people just really are meant, I believe, that you cross paths for a reason. And you really enjoy taking care of them, and you really care about them as a person. And you don't want to see them go because you enjoy the relationship that you have with them. And that is completely normal. And that has happened to me so many times, especially when I was an oncology nurse. I just would be heartbroken when I would take care of these patients for, days at a time, and then they would go home. And, I would miss seeing them when I come to work, and I would miss being able to contribute some type of positivity to their day. And then I always wonder what happens to them when they go home. That's the worst part, is that I never am going to know the outcome, especially for cancer patients. Are they going to die? Do they go to hospice? Do they get cured? Do they get married? Do they have kids? What happens? That's the part I don't like, is that I have kind of like this vested interest in them, but then I don't get to see them past the hospital. So there is regret about ending a satisfying relationship, even though there's a sense of accomplishment there. If the goals have not been achieved, the patient might experience anxiety and fear about the future. What's going to happen? I haven't met this goal. I'm going to be discharged today. What's that going to look like when I get home? Whatever the feelings are, you should always encourage your patients to express their emotions about the termination. You can prepare for the termination of that helping relationship, that nurse-patient relationship, in various ways. It is thoughtful to help set the stage for the patient to establish a helping relationship with another nurse, if appropriate. You can also assist the patient transferring from one facility to another. So helping that patient establish a relationship with another nurse. A good example of that is when you're doing bedside reports. Sometimes you know ahead of time, before the end of your shift, who's going to get your patients that night. I don't always go to the front and look at the schedule, but if I do know who it is, about 6 o'clock when I go in to make my final rounds, I'll be like, Mr. Edwards, it's getting to be that time of day. It's going to be 7 o'clock soon, and I'm going to be going home, but I know that your nighttime nurse is phenomenal. Anne's going to be your nighttime nurse. She's worked here for 10 years. You are in great hands. She's going to take phenomenal care of you. And when 7 o'clock comes, she's going to come to the room. I'm going to say goodnight to you, and then I'm going to introduce you to her. She'll put all her information on the board, and you'll be squared away. So that is one way that you can set the stage for terminating that relationship, and that way the patient is prepared. So assisting the patient transferring from one facility to another, you're going to call that facility and you're going to give report. You're going to call and you're going to say, hi, this is Trish from GBMC. I am transferring Mrs. Jones to you today. She's coming to room 2536. I wanted to give you report. And then you get that person's name and number that you gave the information to. You go back to the patient and you say, Mrs. Jones, I called over to Stella Maris. I spoke to Rebecca. I gave her report. She's going to be waiting there when you get there. The ambulance is going to take you there. I gave her all the information about you that she needed to know. You're in good hands. We printed off all the information about your medications and your past medical history and the treatment that we performed while you were here. They're going to have all that, and they're going to know exactly where to pick up where we left off. So you're preparing the other facility, and then you're also preparing the patient as well. So factors that promote effective communication. So there are dispositional traits, which is a characteristic or a customary way of behaving. So there's warmth and friendliness, there's openness and respect. Most of you guys know what this means. There's empathy. We talked about empathy. There's honesty, authenticity, and trust. There's caring, there's competence, and then seeing through the eyes of the patient. Then there's rapport builders, which is a feeling of mutual trust experienced by a person in a satisfactory relationship. So there are specific objectives. You want to make sure that you're in a comfortable environment. This helps build mutual trust when the patient is comfortable and they can really listen to you and you guys can talk things out. You want to make sure that you're providing privacy. So if it's kind of hard if a patient is sharing rooms, but you want to pull that curtain. You want to maybe talk a little bit quieter if you can. If they're in one room by themselves, you want to make sure you shut the door. You want to maintain confidentiality. If there's other family members in the room, you want to get the patient's permission before you talk about his medical history in front of the patient. If family members call in on the phone, you want to make sure that you're confirming with the patient that it's okay that you give out information for them. And then you have patient versus task focus. Focus needs to be on the client and the client's needs, not those task-driven things like straightening up the room, measuring eyes and nose, passing medications. Those are all your task-driven tasks. And then utilization of nursing observations. So you want to make sure that you are paying attention to what you're observing, and then utilizing that information correctly by acting upon it and putting that into your nursing care plan, and then optimal pacing. Okay. So using a handoff communication, this is SBAR. We talked about that earlier. That is your situation, okay? This is what's going on with your patient. So if you want to call and talk to Dr. McDonough about Mrs. Jones' blood pressure or that crushing chest pain, that's the example I think we used earlier. This is the situation. So you could fill this out on a piece of paper. After you do this enough times, it'll just stick into your mind, and this is how you will call when you're giving handoff or if you're calling a doctor. So this is the situation. Mrs. Edwards came in because she was having difficulty breathing and left chest pain throughout the shift. She delivered crushing chest pain on a scale of 9 out of 10. We did an EKG on her, which was negative. She was normal sinus rhythm. There was no abnormalities at all. The doctor ordered a CT scan of her chest, which was also negative. There were no pertinent findings. We did change her pain medication to this, 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 and this. So this is the situation. Then you have the background, which is what's going on. What did she come in for? This is kind of hard for me to see. I need this to be bigger. Let's see. I'll make mine a little bit bigger. I can. Give me just a second here. I have old eyes. So the background is the patient's mental status. Are they alert and oriented? What is their skin like? The patient is on 2 liters of oxygen, or they're on room air. Their pulse ox is 92. This is just the background based upon your situation, more information that you want to give. And then you want to talk about your assessment. So this is what I think the problem is. Maybe she has a history of anxiety and you had been in her room previously and you guys were talking about, you know, you could say, Dr. McDonough, when I was in the patient's room just an hour beforehand, she was very concerned about paying her bills, who was going to take care of her dog and her cat. There was no one at home. She doesn't have any family nearby. She was breathing heavily. She kept grabbing her chest, and she has an extreme history of anxiety. She takes X, Y, and Z for anxiety, and she hasn't had any of her meds today. This could just be some of her anxiety acting up. It doesn't mean you're diagnosing the patient, but you spend a lot of time with the patient and you know more about them sometimes than the doctors do. So it is okay if you offer your professional opinion. So that's your assessment, and then your recommendation. What do you want from the doctors? Do you think you would be able to come and see the patient? Can you guys come put your eyes on them? Do you think it would be okay for you to do her medicine requisition in the computer, and let's get some of her normal medicines that she takes for anxiety? That really might help her. Can she get a one-time dose of Xanax? And that will really help her calm down. So what is your recommendation? So that's your SBAR, your situation, your background, your assessment, and then your recommendation. So developing, oops, hold on, I gotta make my screen smaller again. All right. So developing good conversation skills. So you wanna make sure you control the tone of your voice, that you're conveying exactly what you mean to say and not a hidden message. Your tone should always indicate interest rather than boredom, patience rather than anger, acceptance rather than hostility, and so forth. So it's very easy to become overwhelmed in nursing. You have a lot of things to do in a very little time. And sometimes you may start your day thinking that you're going to get all your meds done by 10, but sometimes it's 9:55 and you've only seen one patient because that patient was so acutely ill, and then maybe they fell on the floor and you had just a crazy morning. That's how it goes in nursing. And when your patients are just talking about something that you don't think is important at the time, our body mechanisms and the way we look and the way we talk can convey that, you know, we want you to stop talking and we need to give you your medications. I got to hurry up and get out of your room. And that's not something that we want to do. And it might not even be something that we intentionally do. It might happen by accident because we know that we have to get over to our next patient who still needs their medication. So we want to be careful about the tone in which we talk to our patients and our body mechanics. We want to be knowledgeable about the topics of our conversation and make sure that we have accurate information. So if you're going to give a patient a pill, that you don't know nothing about, and the patient says, well, what am I taking this medicine for? Oh, I don't know, it's just part of your morning medications. Well, that's not acceptable. But it's okay if you don't know. It's okay to say, you know what, Mrs. Jones, I'm not exactly sure. I don't think I've ever given this medicine. Give me a minute. Let me go to my medication administration record and let's see what this medication is for. Oh, well, I see here that it helps with gout. Oh, yes, that's right, Trish. I do have gout. I get a pain in my left toe and I take this medicine. Okay. It's okay not to know, but you do need to have accurate information and you need to know where to get that accurate information from. So when possible, be familiar with the subject of the conversation before discussing it with the patient. So when you're going through your meds in the morning, if you see that you're pulling a med that you don't know what it is, make sure you look it up before you go in the room. It helps you to be better prepared. You can, if the topic is unfamiliar to you, for example, the availability of community resources for a family member, the patient, or a caregiver with special needs, you admit to the patient and the family that you really are not sure what information they need, and you can direct them to other resources. So you can say, you know what, I don't really know a lot about the clinics in your neighborhood that would offer X, Y, and Z, but I know the social worker does a lot of that work and that's her expertise. Let me schedule a time for the social worker to come and meet with you, and she can help you set that up in the community once you're discharged. Okay, so that's being able to know other resources to meet the needs of your patients. You want to be flexible. You might want to discuss a certain subject, but learn that the patient wishes to discuss something else. So you have to wait your turn, listen to what they have to say, and then wait for the opportune time for you to discuss certain things. It's better to follow the patient's lead when possible, and you can read, and then when your time arises, you can return to the subject that you originally wanted to talk about. Be clear and concise and make statements as simple as possible. Your patients can be anxious and they fail to understand messages unless the patient's understanding the language that's used. And sometimes when they're anxious, they hear what they want to hear and not exactly what you're saying. So it's important for you to stay on one subject at a time, and this helps to prevent confusion. You want to avoid words that might have different interpretations. So study the meaning of words. Studying the meaning of words is called semantics. So even when two people speak the same language, some words such as love, hate, freedom, and health might have different meanings to different people. You want to be truthful. Always, always, always be truthful. This is something in a life lesson, not just being a nurse, but just in life in general. Always be truthful. A patient who is given false information will learn to distrust the nurse. You will not have that helping relationship, that good nurse-patient relationship. The patient's not going to trust you. They're not going to tell you things. They're not going to confide in you, and it's going to impede the care that they receive. If you're not sure about something, admit that you don't know and seek the answer rather than make a comment that may be an error. I say this all the time. I just said it last week. I'm not really sure about that. Let me find out. And the patient didn't think any less of me. He had more respect for me because I was honest. And then I think of what would I do if I was the patient? How would I want the nurse to handle it? Well, I would want them to be honest with me, and I wouldn't think any less of them if they didn't know something. You want to keep an open mind. The attitude of I know better than the patient because I have an education is a quick way to make an enemy with your patient. Patients can make valuable contributions to their own health care. Maybe they have done research. Maybe they take their medicine like they're supposed to. Maybe they know the side effects. Maybe they take their blood pressure every day. So we aren't the end all be all. We don't know everything, and we need to listen to our patients. Take advantage of available opportunities during most caregiving situations. You can facilitate conversation that makes even the most routine task seem very meaningful for the patient. So when you're giving a bed bath to a patient, you can ask about the patient's family members. How many kids do they have? Are they married? Do they have grandchildren? Where do they live? Are they retired? What kind of work do they do? You can always make conversation while you're accomplishing other things. This allows the patient to verbalize any positive or negative feelings and about being temporarily, maybe if they're retired, maybe they missed their job and they're having lonely feelings because they don't feel needed anymore. It helps reduce anxiety and takes away from the reason why they're in the hospital. And it just establishes a good rapport with your patient. Whoops. All right, so developing listening skills. So when you're listening, oh, conversation skills, I'm sorry. Nope, we just said that. Listening skills. So when possible, sit with your patient when you're communicating with them. Don't cross your arms or legs because that body language conveys a message of being close to what the patient is saying to you. Make sure that you're present, make sure you're making eye contact, you're relaxed, you're alert, and you're taking a sufficient amount of time so that the patient feels at ease when they're talking to you. You don't want to make them feel like you're rushed and that you're half listening to them because you have 100 other things on your mind. You want to keep the conversation as natural as possible and avoid sounding overly eager, but you do want to make the patient believe that you genuinely care about them because you should. If culturally appropriate, you can maintain eye contact with your patient without staring like in a face-to-face position. This technique conveys interest in the conversation and your willingness to be present with the patient and really listen to them. You want to indicate that you are paying attention to what the patient is saying by using appropriate facial expressions and body gestures. So you're making that eye contact with them, you're listening, you're nodding at appropriate times, you're acknowledging what they're saying. You want to be attentive to both your own and the patient's verbal and nonverbal communication. So really think about the way that you're listening to them. Even if you're tired of listening to them and you know you have 100 other things to do, are you rolling your eyes? Are you huffing and puffing? Are you crossing your arms? Are you slouching up against the wall? So you have to be conscious of your own verbal and nonverbal communication. You want to think before responding to the patient. Responding impulsively tends to disrupt communication and listening. So you want to make sure that the patient is finished talking before you start talking. And you don't want to pretend to listen. Most patients are sensitive to an attitude of pretending to actually listen, and they can tell if you're bored and you're really not paying attention to them. You want to listen for themes in patients' comments. So what are the repeated themes in a person's speech and behavior? What topics do the patients tend to avoid? What subjects tend to make the patients shift conversation to other subjects? What are inconsistencies and gaps that appear in the patient's conversations? And then you want to use, you can just use silence. Silence is, sometimes you don't have to say anything, and that's just the best thing in the world. They just want to be able to say what they have to say. You can offer a therapeutic touch. If they say something that upsets them and they start to cry or they get emotional, you can put your hand on their arm, you can put your hand on their hand, you can give them a hug. Sometimes it's okay to make a joke if it's appropriate, because it kind of takes the patient away from being so focused on the negative, and it, kind of makes them laugh for a minute, but it has to be appropriate. So listening effectively is a key to a productive communication. This is in every aspect of your life, whether it's nursing home, your marriage. Listening is extremely important. You have to listen to what other people are saying. So there are interviewing techniques. So the purpose of you doing that patient interview is because you want to get from the patient accurate and thorough information. The interview that you do on your patient when they're admitted is a major tool for collecting all the data during the assessment step of that nursing process. You remember we talked about that nursing process, and we're gathering all that data, right? So when you're obtaining a nursing history, you want to make sure that you are using open-ended question, the open-ended question technique, which allows the patient a wide range of possible responses. It prevents them from just saying that yes, no. It allows the patient to express what they understand to be true, yet it's specific enough to prevent digressing from the issue at hand. It encourages free verbalization from the patient, and the greatest advantage of this technique is that it prevents the patient, like I said, from giving that yes or no answer that limits the patient's response. So an example of a good open-ended question and a response from the patient would be, the nurse would say, what did your healthcare provider tell you about your need for being hospitalized today? Well, he told me that my blood pressure is dangerously high and that I need to get some special tests done while I'm being hospitalized. So you can see the information that the patient gave you was very detailed based upon that question that you used, that open-ended question. A closed question provides the receiver with very limited choices of responses and might often be answered in just 2 words, like the yes or the no. The closed questions are used to gather specific information from a patient and to allow the nurse and the patient to focus on a particular area. So examples of closed-ended questions are this type of question or hold on a minute. The nurse says, what medications have you been taking at home? And the patient says, let me see, my doctor gave me a water pill and a blood pressure pill to take every day. So that's a good example of a closed-ended question. So you want to validate what you believe. It can be a question or a comment. You want to validate what you believe that you've heard or observed. Overusing validating questions or comments might make the patient think that you're really not listening. And a good example of that would be the nurse says, at home, you have been taking both a water pill and a blood pressure pill every day. Did you take them today? And the patient would say, yes, I took one of each at breakfast today. So you are validating what you heard and you're clarifying it by answering a question and a statement combined. The use of that clarifying question or comment allows you, the nurse, to gain an understanding of the patient's comment. When you use it appropriately, this technique can prevent impossible misconceptions that could lead to inappropriate nursing diagnoses. The overuse of clarifying questions leads the patient to believe that they're not listening or that you lack the appropriate knowledge. So an example would be the patient says, I have never needed to take medicine before in my life. And the nurse says, is this the first health problem you've ever had? And the patient says, yes, I've always been healthy. Then you have the reflective question, which involves repeating what the person has said and describing the person's feelings. It encourages the patients to elaborate on their own thoughts and their feelings. So I go back to the example of the patient who was scared because she didn't want to have the hip surgery because she was scared she was going to die and she was really missing her family. So what the nurse would say is, Mrs. Jones, from what you're telling me, it sounds like you do want to have the surgery because you know it's going to help your hip, but you're really scared that something bad is going to happen during your surgery. And you're really sad because you don't have any family member here. Is that right? So you are reflecting back to what the patient said. You're repeating them. You're describing it in their own words, and you're validating what they're saying. There's sequencing questions, which are used to place events in a chronological order. Or you can investigate a possible cause and effect relationship between events. So a nursing assessment is facilitated when events leading to a problem are placed in sequence. And this technique is evident with the following example. So the patient says, I don't like myself anymore since I've been taking my blood pressure medication. I'm tired and I don't have any energy. And the nurse says, your tiredness began after you started taking your medication. So you are building on what the patient said, and you are verifying that what the patient is saying, that they started to become tired after they started taking their medicine. Okay, so it is a cause and effect relationship. The way the patient feels was caused by the blood pressure medicine. And then you have direct questioning or direct comments. So sometimes you need to obtain more information about a topic that maybe the patient brought up earlier in an interview, or you want to talk about a new aspect of a current topic. This is a way that the nurse can gain additional important information to consider in assessing the patient's health status, any educational needs or counseling needs that they may have. So a good example of this technique would be, the nurse says, you mentioned your dad earlier. Did he develop complications related to high blood pressure? And the patient says, yes. Well, what sort of complications? The patient says, kidney failure. He was on dialysis for years before getting a transplant. And then the nurse says, are you afraid this might happen to you? So there was some information that was brought up earlier during an interview, and that made you believe that this was something that was important to the patient. You brought it up again, you elaborated on it, and you were able to get more information about what could be bothering the patient. All right, so characteristics of The assertive nurse's self-presentation. So when you interact with patients, their family members, other nurses on the floor, doctors, healthcare team members, you have to communicate in a way that demonstrates respect for everyone that you're dealing with. Assertive behavior is the ability for you to be able to stand up for yourself and use open, honest, and direct communication. The focus is always on the issue and not the person. Assertive behaviors, which are an extremely important component of professional nursing relationships, are completely different from aggressive behavior. So assertive behavior and aggressive behavior is completely different. The key to being assertive is expressing your feelings and beliefs, but this happens in a non-defensive manner, okay? Assertiveness, you can express your thoughts, your feelings, and your beliefs, but it occurs in a non-defensive manner. So statements like I feel and I think play a very important role in any assertive statement that you have. The use of assertive behaviors in communication respectfully expresses your views, opinions, and concerns regarding patient care without any type of judgment at all or without blaming anyone else. Characteristics of the assertive nurse's self-presentation include confidence. They have a very open, welcoming body posture. They maintain eye contact with the patients and with the other members of the healthcare team when they're speaking. They use very clear, concise I statements and the ability to share effectively their thoughts, their feelings, and their emotions in a non-defensive manner. The assertive nurse's attitude towards work is always characterized by working to the full capacity with or without supervision, and the ability to always remain calm under her supervision, under the supervision of their supervisors, and the freedom to ask for help when necessary. So they recognize when they're drowning, they're able to work under people, and they don't have a problem asking for help to accomplish things. And they have ability to give and accept compliments. So they take compliments when they've done something well, and they give compliments to others to build people up. And they have honesty in admitting mistakes and taking responsibility for them. So the example that I gave you when I forgot to give my patient his water, and I've told him quite honest, just very frankly, I am so sorry. I completely forgot to come back to your room. I went into another patient's room and this is what happened. And I'm really sorry. I forgot to give it. So that is a good quality for an assertive nurse. So an assertive nurse, if there's a problem on the floor with a nurse that may be taking some extra time for lunch and expecting other people on the floor to take care of their patients, this is an example of a conversation that could take place. So if you have an assertive nurse and this happens when the nurse comes back from lunch after they've been gone for 45 minutes instead of just a half an hour, the assertive nurse would say, you know what, I know we all lose track of time occasionally, but I'm finding it harder and harder to cover for you when you take extra time for lunch. I don't think it's fair for your patients and me to have to wait an extra 30 minutes every day for you to come back for your lunch. Can we talk about this? Okay. The non-assertive nurse would handle it like this. That nurse that took 45 minutes for lunch would come back and she would say, no, I didn't really mind watching your patients. Luckily, I wasn't too busy today. But in your mind, you're thinking, wow, I'm a sucker. Now I have to grab a quick bite so that I can get back to the unit in time to do all the treatments and medications that I have to do now because my lunch is cut short because she was gone forever. So the non-assertive nurse will just brush it under the rug, make excuses, and they won't deal with it head on. The aggressive nurse, okay, would be, and we all probably want to be this aggressive nurse sometimes inside of our minds, that interpersonal conversation that we have with ourselves. She would say, I'm sick and tired of covering for you. You're lazy and unreliable, and I'm going to talk to the unit leader about you and let her know how irresponsible you are. What kind of nurse are you? I hope you lose your job. So you can see the assertive, the non-assertive, and the aggressive. So you want to be that assertive nurse. It is very easy to be that non-assertive nurse, especially if you don't like confrontation. And then if you don't think before you have a conversation, that aggressive nurse could come out. I could see that happening in me if I don't think before I say things. So aggressive behavior involves asserting one's right in a negative manner that will ultimately violate the rights of other people. It can be verbal or physical. Communication is then marked by tension and anger, and it inhibits the formation of a good relationship, that helping relationship, that nurse-patient relationship, and collaboration with other healthcare team members. The characteristics include using an angry tone of voice, making accusations, and demonstrating belligerence and intolerance of a situation. Aggressive behavior is rude and threatening, and it's not welcome in the healthcare field. It's actually not welcome anywhere, especially in the healthcare field where people are sick. Comments like "do it my way" or that's just enough out of you, I don't want to hear what you have to say, that's completely not acceptable. Focus for these people is usually winning at all costs. They have to be right no matter what it costs. If it costs the patient, if it costs other members of the healthcare team, whatever the cost, they have to be right, and their focus is usually on winning. People speaking in an aggressive manner may invade other people's personal space. Remember, we talked about that personal space and how far apart you should be. Speaking loudly is intimidating, and it causes attention to the situation. Using gestures that are very empathetic or threatening. And then aggressive people enhance their self-esteem and prove their superiority through destructive comments directed at others. So that's just how some people make themselves feel better, by being mean to other people. And that's just a life lesson. You're going to encounter people like that through your entire life, unfortunately. So blocks to communication. So nurses have to always remember to focus on the whole patient and not just the diagnosis. Patients report that nothing is more discomforting than to be treated as just an object of care rather than a patient. Patient should be addressed by a formal name. We talked about that earlier, Mr., Mrs., Mrs., or Doctor, rather than slang term like honey, boo-boo, sweetie pie, apple dumpling, sugar nugget, sweetie, whatever. And what distinguishes nursing from other healthcare professionals is that we focus on the whole person, not just their illness or their dysfunction. We focus on everything. It's a holistic treatment that we provide. And that sets us aside from doctors and other types of healthcare providers. Often, the signs that patients give off indicating that their readiness to talk are very subtle, and we don't always notice them. So you don't want to miss valuable opportunities for important communication by approaching a patient with a very closed mind or focusing on your own needs and what you have to do that day. You want to be present with that patient, and make sure that you are able to listen to them. Oops, did I go to the right slide? Here we are, I'm sorry. Certain types of comments and questions should be avoided in most situations, because when you use them, they tend to impede any kind of formation of any effective communication. And some of those things that we want to avoid are cliques, so any stereotypes, or using, like your doctor knows best. You're in good hands, just don't worry. You're fine. You're in the best hospital around. You want to avoid saying things like that. You want to avoid those closed questionings, yes or no. You want to use questions containing the words why and how, because these allow your patients to produce more detailed answers, okay? They tend to produce answers that are good for you, more detailed answers, but sometimes your patients might not respond honestly. So you want to try and phrase them a little bit better, okay? Using questions, you want to avoid using questions that probe for information. Clients feel like sometimes you're giving them the third degree, or you're really digging deeper than you should for just the relationship that you have, which is that patient-nurse relationship. Other blocks to communications, so using leading questions. A leading question is suggests what response the speaker usually wants to hear. So leading questions produce answers that might please the nurse, but are very unlikely to encourage the patient to continue speaking honestly without feeling intimidated in this situation. So if a patient says, is it okay if I go off the floor? I want to grab something from the vending machine. And then the nurse says, you're not going to go off the floor to smoke a cigarette, are you? You have been well cared for by your nurses, haven't you? Well, these questions are going to direct that patient to answer, okay, to give an answer that's going to please the nurse rather than to express their own thoughts. And you can see how that could happen. You want to avoid using comments that give advice. So giving advice often implies that the nurse knows what's best for the patient, and we don't always know what's best for the patient. And it denies them the right to be able to make their own decisions and have their own feelings about their care. It also increases the patient's dependence on caregivers because they feel like they don't have a say. And then, however, the advice does have a rightful place, but you have to make sure that it's requested. And when the person giving the advice has expert knowledge that the patient does not. So when you're educating them something about maybe their new pain medication, things that they don't know anything about, okay, you have to make sure that the patient wants your advice. You want to avoid judgmental comments because they impose the nursing standards on the patient. It doesn't matter what you believe or what your biases are. You have to remain non-judgmental when you're providing care to your patient. You want to avoid changing the subject. When you're talking to your patient and listening to them, they might be ready to have a conversation with you, and then you quickly change the subject. It shows the patient that you don't really care about what they're saying. We talked about giving that false reassurance. So when the patient says, I'm afraid that I'm going to die in the operating room, you don't want to say, well, you could die, or you don't want to say you're not going to die. You're going to be completely fine, because we can't guarantee that that's really going to happen. So we don't want to give a false sense of assurance. We want to avoid gossip and rumors, okay? They are considered common forms of communication, particularly in the healthcare setting. You'll hear people say, I heard through the grapevine that Melinda in labor and delivery got fired because she was stealing medication. So gossip and rumors can produce very detrimental effects on relationships with your coworkers, and it can prevent group building. Gossiping might be used to inform, influence others, entertain, or ventilate, and it can seem harmless, but it can also do have very damaging consequences to the patient's reputation that you're talking about. And you want to avoid disruptive interpersonal behavior and communication. So any type of disruptive behavior has a negative effect on clinical outcomes and those interpersonal relationships that you are trying to build. Adverse events can occur when communication between healthcare professionals is not effective, if it's abusive, or if it's negative, because then the most important thing that brings that patient and the nurse and the healthcare team together is that common goal of providing the best patient care. So if there's disruptive behavior and you don't get along with the person who's doing PT because they said something about another coworker of yours, then that's ultimately going to have a negative effect on the patient, because you're not going to be able to work effectively with them and keep the goals of the patient in mind. So that's ultimately going to affect their care. And the Joint Commission has established a leadership standard that actually requires hospitals and any other type of an accredited institution that they have to establish codes of conduct that define behaviors that are acceptable, disruptive, and unacceptable. And then they require that the staff be educated upon those. And I know that my facility has those, and we go over them yearly in our competencies. We have to watch a little video and answer some questions about it. So my facility does that. We are almost there, guys. I know this is a lot of information. So now we're going to talk about disruptive interpersonal behavior. So incivility and bullying. So incivility is rude, disruptive, intimidating, and undesirable behavior directed at another person. It also includes failing to act when an action is warranted, such as refusing to assist a coworker or share important information about a patient's care because you don't get along with them, or you don't like the type of nurse they are, or you don't like the physical therapist. So that's when you fail the patient, and then you fail to act when you should have done something because you didn't want to be bothered with the coworker, or you didn't want to share information because you don't get along with someone. Incivility is considered by some as a precursor to bullying behavior or even lateral violence. And by others, they think other people just see it as another form of bullying. So anger and aggressive behavior between nurses or nurse-to-nurse hostility has been labeled what we call horizontal violence. It's a negative behavior, and it can also be referred to as bullying. You might hear it referred to as lateral violence and professional incivility. Myself, I've just heard it as bullying or lateral violence. All of these are forms of psychological and social harassment, and they involve covert and overt behaviors, and we're going to talk a little bit more about that. Covert bullying includes withholding information from a colleague, gossiping, spreading rumors, using nonverbal communications such as eye rolling and other body language, and then social isolation. Overt bullying includes accusing a nurse of errors made by someone else, so scapegoating, or humiliating a person in the presence of others. Those are some pretty serious things. I can honestly say that in this almost 7 years that I've been a nurse, I've never actually seen that happen in the workplace. I've seen people that are a little bit cliquey and they talk about people here and there, but in their own little thing, I've never actually seen anybody be bullied in the workplace. I know that it exists. I've heard of it. I just haven't seen it. But it is something you have to be aware of, and you kind of have to pay attention and look around and be aware of your environment. The physical and emotional toll that it takes on people that are employed in a toxic work environment can be very significant. Commonly reported physical consequences include people that suffer from frequent headaches, they have sleep disturbances, they have GI issues, they have decreased energy. Psychological manifestations are increased level of stress. They might have anxiety, fear, frustration, a loss of self-esteem. Those all can escalate and cause burnout and then emotional exhaustion. Bullying also affects patient safety because teamwork is negatively influenced, which results in deterioration in the quality of care and the greater potential for error. So if the nurse and the tech that are working together don't have respect for each other and they don't like each other and there's bullying that's going on, it's possible that maybe they don't talk in the morning and they don't give report to each other in the morning, and maybe the nurse didn't tell the tech that Mrs. Jones was a high fall risk and that her bed alarm needs to be on and that she needs someone to walk her to the bathroom. So if that information isn't communicated, it's possible that Mrs. Jones may have a fall throughout the day because the tech doesn't know and she doesn't set that bed alarm and she doesn't stay with the patient when she's walking them to the bathroom. So these behaviors definitely have an effect on your patients. The ANA, like we said before, states that the nurse and employers in all settings have an ethical, a moral, and a legal responsibility to create healthy and safe work environments for nurses and every member of the healthcare team, from housekeeping all the way to doctors. For healthcare consumers, families, and their communities, nurses and their employers must collaborate to create a culture of respect that is free from incivility, bullying, and workplace violence. We also have, this is one of the things that we do competencies for at my job. We do a competency every year. It tells us where to go to speak to someone if we're having an issue. Excuse me. And it helps us recognize potential problems in the workplace. All right, let's see. Documenting and reporting, conferring and using informatics. This is next. We're getting there, guys. We're getting there. It's a lot of information. So documenting care. So documentation is what we consider the written or electronic record of all pertinent interaction with the patient. It's assessing, diagnosing, planning, implementing, and evaluating. Add PI, right? Assessing, diagnosing, planning, implementing, and evaluating. And the old adage is, you'll hear this 100 times, if it wasn't charted, it wasn't done. So if Mrs. Jones, if you put her bed alarm on and you put high fall risk socks on her and she had a fall, but you never documented that you implemented those interventions, guess what? It wasn't done. Even if you said it was done, even if you know you did it, it still wasn't done. If it's not charted or documented, it's not done. Documentation is what we, documentation are the records that contain data used to facilitate quality. It monitors evidence-based care. It serves as a financial ledger. This is how we get paid. This is how people go through the charts and they determine codes and they bill when we get money. And it also is a legal record. It can help in clinical research and it can support decision analysis. Information specialists aim to create an environment that supports timely, accurate, secure, and confidential recording and use of patient-specific information. So your documentation should be consistent with your professional and agency standards. So whatever they expect for you to document during the day, you should be documenting it. You should be documenting it how they want you to document it according to their standards. Your documentation should always be complete. So if you have a list of 15 things that need to be documented each day, each thing should be documented each day, and every box should be checked and every requirement should be complete. It should always be accurate. It should be the most accurate data. You want to make sure that you're assessing that patient every single day. If you work 3 days in a row, you don't want to document today what you saw or heard yesterday. Things change and your documentation is always in present time and it should be accurate. It should be concise. It should be factual. Remember, we don't want to state opinions. We want to make sure that what we document is factual. It should be very organized and have a certain flow, and it should be timely. You want to make sure that if you're not documenting at the time that it happens, that when you go back, that's the time that you put in, is the time that it occurred. And it should be legally prudent and confidential. So you can go to page 456. You can look at box 19.1 and it'll offer some more documentation guidelines for you guys to look at. So elements of documentation. So your content. So you want to enter information in a complete and accurate, concise, current, and factual manner. We just said that on the other slide. You want to make sure your documentation reflects that nursing process and all of your professional responsibilities. You want to record patient findings, so any observations of behavior, rather than your interpretation of these findings. You have to document things that you can actually see. You want to avoid words when you're documenting or writing notes, such as good, average, normal, or sufficient, because this may mean different things to different readers. So you want to stay away from terminology like that. You want to avoid generalizations such as the patient seems comfortable today, because there you're making an assumption. Are they really comfortable? Well, to you, they seem comfortable, but it might not mean that they are comfortable. So a better way for you to enter that would be on a scale of 1 to 10, the patient rates their back pain as a 2 out of 3 today, compared with 7 to 9 yesterday, and their vitals return to baseline. So that is definitely a more accurate generalization for you to describe how the patient's feeling. You want to avoid using words such as good, average, normal, or sufficient, which may also have different meanings to, we already said that, sorry, different meanings to different readers. You want to note problems as they occur in an orderly, sequential manner. You want to record the nursing intervention and the patient's response, and then update problems or delete as appropriate. So sometimes if I'm really involved with a patient that has a lot of stuff going on, I can't actually go in and note exactly what's happening at that time. So I keep like a progression of what's happening on a piece of paper on my computer. So I will type what time, I will write down what time I called the doctor, what I called them for, and what happened. So if I call the doctor because the patient blood pressure is very elevated, I'm going to put a note that at 1400 I called Dr. McDonough because Mrs. Jones' blood pressure was 201 over 115. I'm going to put in there what the patient's signs and symptoms were. I'm going to put in there that we had new orders received. I'm going to put in that I gave the medication as administered, and then I will continue to monitor the patient. Then I'm going to continue to monitor that patient. I'm going to continue to check their blood pressure, and then I'm going to go back in and put another note that the medication was given, and then I retook the vitals, and these were the vitals, and this is the patient on the status. So it's that continuous ongoing process. So if you had a situation that warranted you calling the doctor, you need to document that. And then you want to document if there were any new orders. What did the doctor do? You can't just document that your patient has uncontrolled blood pressure and not document what you're going to do to fix it. Sometimes the doctors don't do anything to fix the problems. They just want to sit and watch and wait. So in that circumstance, you would still put that note in that you contacted Dr. McDonough about Mrs. Jones' blood pressure. Patient is asymptomatic at the time, resting comfortably in bed, put in the vital signs, and then say no new orders received. So that way you're covering yourself that yes, you did talk to the doctor, you expressed what was going on, but you didn't receive any orders at the current time. So you want to record any precautions or preventative measures that you've used. So if you have a patient that's a high fall risk, you're going to document in your note that they have a red set of red socks, that non-skid socks, that you put a red bracelet on them, that you have their bed lowered and their bed alarm on. These need to be part of your documentation, because if it didn't happen, then it wasn't done. If you didn't do it, it never happened. You want to document in a legally prudent manner. So you have to know and adhere to the nursing standards and the facility and institutional policies for documentation. So if your institution requires that if you give an IV blood pressure medication that you do vitals every 4 hours, you need to make sure that you're doing vitals every 4 hours. Your computer system is not going to prompt you to do that, but you have to be aware of the medications you're giving and the policies that go along with them. So that's legally documenting in a legally prudent manner. You have to document the nursing response to questionable medical orders or treatments. Factually record the date and time that the healthcare provider was notified of the concern and the exact healthcare provider's response. We just talked about that. If it occurs by phone, you want to have a second nurse listen to the conversation and co-sign the note. If a nurse administrator was contacted, you want to put that in the documentation. And documentation should give legal protection to the nurse and other caregivers, the healthcare facility or institution, and the patient. You want to avoid any stereotypes or derogatory comments when charting. The patient, you wouldn't want to say, Mrs. Jones is extremely ignorant, unprofessional. She called me names and refused to take her meds. You don't want to leave that. You don't want to put those things in your documentation, and you want to refrain from copying and pasting notes in an electronic health record, because this data could be outdated or inaccurate. You want to type it in real time, and it should be your own information. The timing is very important, so you want to document in a timely manner. You're going to follow the policy that your facility policy regarding the frequency of documentation. If you forget to document something, record it as soon as you can. Follow the procedure for making late entries. Example, you're actually going to type late entry. Patient reported passing gas at 8 a.m. this morning, but no stool yet. Notified the surgical resident, Dr. Cotter, and then you're going to put your name with RN behind it. You're going to indicate in each entry the date and both the time the entry was written and the time of the pertinent observations and interventions. This is crucial when a case is being reconstructed for legal purposes. So at 8 o'clock, Mrs. Jones's blood pressure was taken. At 8:15, I contacted Dr. McDonough. At 8:20, I gave the medication. At 8:35, I checked the blood pressure again. At 8:45, I documented that the blood pressure had come down to a normal reading. So you want to have that that timeline that shows exactly when things were done. Because if something were to go wrong and this would end up in a legal battle in court, you want to be able to have all your ducks in a row, that you did what you were supposed to do at a timely manner. If you document at 8 o'clock that the patient has this elevated blood pressure and there's not another note in there for the rest of the day, then that's going to look like that you never followed through and never did anything for the patient, and it could cost you your license. So it's extremely important that you are very good about your documentation. You want to document nursing interventions as closely as possible to the time of their execution. The more seriously ill the patient, the greater need to keep the documentation current. Never leave the unit for a break when caring for a very seriously ill patient. Until all the significant data has been recorded. So if your patient is possibly being upgraded to another unit or they're really, really sick, that's not the time for you to go and have a lunch break and just leave everything up in the air. Even in these serious situations where you're doing a lot of hands-on stuff like medications and vital signs and things like that, you don't have time to write that note. But like I said, you can keep a progression on your board, because you're not going to be able to remember the exact times. It's impossible to. So I document it as it's going along. And that way, when I get the patient stable or I get a quieter time in my day, I can sit down and I can give them that I can write that note accurately and have all my information that I need. So you will never want to document interventions before carrying them out. So I followed a nurse one time when I was shadowing who wanted to do a dressing change on a patient. It was supposed to be changed during day shift. Well, she went ahead in her documentation and put that she changed it. She documented what it looked like, and she hadn't even seen it because I was with her. And I said, I'm just curious, why would you document that before you actually saw it and changed the dressing? And she was like, well, because I'm going to do it anyway. She's like, and if I don't, I'll just go in and delete it. Well, that patient wound up being discharged to a long-term care facility before she could actually go and do that dressing. And she never went back in and deleted it. So first of all, it's just never a good habit to document something before you do it, because you never know what's going to happen. And it's lying. It's false documentation, and you can be fired for false documentation. So there are times when I do my entire assessment and I chart it except for the integumentary system, which is skin, because there's been wounds that I can't see, and I leave it blank, and then I make a little note on my paper that says document skin assessment. And then I know when I go back in and I have time to look at that and I change the wound, then I can go ahead and before my shift is out and just fill in that little bit of missing documentation. You want to write a progress note for each of the following instances. So when you get an admission to your unit from the emergency room, if it's a new admit, if you have a patient that transfers to another unit, or if the patient is discharged, you want to write a progress note whenever a procedure is performed. If you sent them off the floor to have something done, or you are the receiving nurse to actually have a patient, to have something performed on the patient, like maybe you're an endoscopy nurse and a patient was coming to you to have an endoscopy or a colonoscopy, you would write a progress note about the condition they were in when they came, what happened, what procedure they had, how they were after the procedure, what their vitals were, signs were like, and their stability before you called report to the next nurse and sent them back. Upon receiving a patient post-operatively or post-procedure, we just talked about that, and upon receiving healthcare providers, communicating with healthcare providers regarding critical patient information like abnormal lab value results. So if you have, let's see, a patient who maybe we drew labs this morning and their creatinine was really high. Normal creatinine is like, less than 1 or 1.03. Maybe it was 2.4. Maybe your patient has kidney issues, and that's considered a high number for your facility. You would want to call the doctor and say, I had a critical lab value this morning. Mrs. Jones' creatinine was 2.15, you would want to go in after you talk to the patient and after you talk to the doctor and document Mrs. Jones' blood pressure, Mrs. Jones' creatinine level this morning was drawn and found to be 2.14. This RN contacted Dr. Madonna. No doctor is aware of patient's lab results. Patient is resting comfortably. No new orders received. So that way you're covering yourself that you did let the doctor know and that the doctor is aware that the patient had an abnormal lab result. And then you want to document for any change in patient status. So if your patient starts to decline and their vitals are all out of whack, if their respirations are high or their oxygen is low, you would want to make definitely a very thorough note about that. You would want to include who you contacted and what interventions you did, because remember what I said, you can't document a problem or an issue unless you also document what you did to solve that problem. Your format, you want to check to make sure that you have the correct chart before writing. There's nothing worse than documenting an entire assessment on the wrong patient's chart. Been there, done that more than once. It's easy to do. You have to just slow down and really pay attention to what you're doing. You want to record on the proper form or the screen that's designated by your facility policy. Most places have electronic health records now, so you're documenting in the computer. With paper charts, you want to print or make sure you write legibly in black ink to ensure permanence. You don't want anyone to be able to come by and erase it like if it was in pencil. You want to make sure you're using correct grammar and spelling, and then using that standard terminology. So remember what we talked about earlier about making abbreviations up in your mind, if making up your own abbreviations that wouldn't be acceptable. Other people need to come behind you and recognize what you wrote and be able to understand it. You want to make sure you date and time each entry with the time that you actually did it. And then you want to record nursing interventions chronologically on consecutive lines. Never skip lines. And then you're going to draw a line through the blank spaces. So if you are handwriting a note and it takes up 4.5 lines, when you get to that very bottom line at the very far right, and we're going to see examples of this, you're going to sign your note, Trish Davis, RN, but then to the left is going to be all that open space. You want to draw a line through that all the way through to where your name is so that nobody can come in and write any information where you've signed your name that makes it look like you wrote it. You want to have accountability. You want to sign your first initial, your last name, and the title to each entry you make. You don't want to sign notes describing interventions that were not performed by you, that you have no way of verifying it, okay? You don't want to use dittos, erasures, or correcting fluids ever, ever, ever. You never, ever, ever you never erase anything, and you never use any kind of whiteout on a chart. If you wrote something erroneously, you draw a single line through the incorrect entry and write the words mistaken entry, or you can write error in charting above or beside the entry, and then you're going to sign it with your name. Then you're going to rewrite the entry correctly. You want to identify each page of the record with the patient's name and identification number, and you want to recognize that the patient record is permanent. It's permanent. There's no way to change it. You want to follow your facility policy that pertains to the color of ink and the type of pen that you should use. In our facility, we're expected to write in black pen. Most medical facilities, that's what they require. And then you want to make sure that your patient record is complete before you send it out to medical records. And then, of course, there's confidentiality. Patients do have a moral and a legal right to expect that any of the information in their patient health record will be kept private. So when you have students in the facility, you're going to want to be familiar with that facility policy that pertains to who has access to patient records other than the immediate caregiving team. And then you want to be familiar with the process they use to obtain access. So you want to make sure you're following those HIPAA guidelines. Most facilities allow students to access the patient records for educational reasons. Students using patient records are bound professionally and ethically to keep any information that they see or hear in strict confidence. All the information they learn by reading patient records. And then actual patient names and other identifiers should never be used in written or oral student reports. You can make up initials, You can put the age and the female. You may not use their actual names. If you're trying to gather information and lab results and you're running out of time, you may not use your phone to take pictures of it. You may not print off things at the computer that have patient information on it and take it home. If you do print things off at the facility, you want to make sure you're disposing of them in the appropriate areas. They usually have an area that's a locked box that has like a slit in it for papers. You put that in there and they're disposed of properly by certain companies that maintain confidentiality. So next is using the 24-hour clock for military documenting time. So in the nursing field, we always do military time. So military time takes some time to get used to, but it's actually very, very simple. And the more you do it, the more you get used to it. So at midnight, it's easiest just to start there. On this clock, it shows that midnight is 2400. We don't usually say 2400. We usually say 0000. That means midnight, 0000. And then it starts from there. So 1 o'clock in the morning would be 0100. 2 o'clock in the morning would be 0200, and so on. You do 3 o'clock, 4 o'clock, 5 o'clock, 6, 7, 8, 9, 10, 11, and then 12, okay? So from 12 o'clock at night, you have 0000. You go all the way through with 0100, 0200, 0300, 0400, and so on, all the way up to 12. You don't put that colon in there between the first two numbers and the last two zeros. It's written just like you see it. And then when you get to noon, that would be 12 o'clock, 12 p.m. And then it changes when you get to 1 o'clock in the afternoon. So 12 o'clock is 12 o'clock, but then 1 o'clock is 13, 2 o'clock is 1400, 3 o'clock is 1500, 4 o'clock is 1600, 5 o'clock is 1700, 6 o'clock becomes 1800, 7 o'clock is 1900, 8 o'clock is 2000, 9 o'clock at night is 2100, 10 o'clock at night is 2200, and then 11 o'clock at night is 2300. And then you go back to midnight with 0000. So it does sound a little complicated, but this is actually a great chart. You can print this out and keep this with you when you go to clinical. And it helps, once you get used to it and you do it all the time, it's just like second nature. So what is confidential? What do we consider confidential information? So any information about a patient that is written on paper, any information about a patient that you speak out loud, or any information that is saved on a computer, it is all confidential. It includes the name, the address, the phone number, the fax number, and the social security number of your patients. It includes the reason why the patient is sick and why they were admitted. It includes any treatments or tests that they've had since they've been in the hospital, and it includes any information about their health, their past health conditions. It's all confidential information. We'll do that in our live lecture. Potential breaches in patient confidentiality. So breaches can occur when there is information displayed on a public screen. So when you have your computer on wheels and you're walking into a patient's room and you have all their information up, and then someone from the outside calls you and says, oh, can you come over to this room real quick? Mrs. Jones fell and hit her head. So then you move your computer into the hallway. All of Mr. Edwards' information is still up, and you walk away from that computer and you leave all that information up. Well, in the facility where I work for, that is a fireable offense. You can be fired for leaving information up on the screen. It is a HIPAA violation. You have to make sure that you lock out of your screen and bring that screen down before you leave that screen. Any other person walking by can get the patient's information. Other patients walking in and out of their rooms have access to that information, and it is a HIPAA violation. Sending confidential email messages via public networks. So if you are, I use the example of that text that we had that nurse send when our computers were down from her personal cell phone with all that personal data in it, listing that patient's name, was wrong. So keeping that in mind, sharing printers among units with differing functions and informations. So unauthorized users can have access to printouts and find out things about your patients. So making sure that display screens do not face public areas. For your portable devices, you can install encryption software that makes information unreadable or inaccessible. You can request that your unit have a separate printer that's not shared with another unit. You want to be careful what you're putting on your copier. So if you're making a copy of something, you want to make sure that you take your copy back and then you discard any copies of that patient health information that's in adjacent copiers or wherever you use. You want to put it in the proper disposal container to be recycled and handled with confidentiality, or you want to make sure that it goes where it needs to go to. You want to use secure disposal containers, right? We talked about those that are kind of similar to mailbox, but a certain company comes and they protect the privacy of the patients and they dispose of it appropriately. You want to hold conversations that other outsiders can hear. So if you're on your patient's cell phone, or if you're on your work cell phone, you want to make sure that you're not standing outside of Mr. Edwards' room, which is next to another patient's room, talking to their family member about that patient. You don't want other patients to know what's going on with other patients, and you don't want other family members to hear what's going on with other patients. You want to make sure whatever you're faxing is confidential and it only goes to the intended person. You want to make sure that you have authorization to fax that information. And before you actually transmit the fax, you want to verify the fax number and that the recipient is authorized to receive that confidential information. And then sending confidential messages on overheard on pagers. I don't think people really use pagers anymore. We don't use them where we are, but I guess that's something else you wouldn't want to use. Questions? Oops. Patients' rights. So patients have the right. Okay, the U.S. Office for Civil Rights enforces the Health Insurance Portability and Accountability Act, which is HIPAA. That privacy rule which protects the patient and individually identifiable health information. According to the HIPAA privacy rule, patients have a right to see and copy their very own healthcare record. They do have to go through the proper channels, so you have to be discharged from the hospital and go to medical records and fill out a form, and there's a process you have to follow. They have the right to get an update of their healthcare record. They have the right to get a list of the disclosures that a healthcare institute has made, independent of disclosures made for the purposes of treatment, the purposes of payment, and then their healthcare operations. They have the right to request a restriction on certain uses or disclosures, and they have a right to choose how to receive their health information. So HIPAA legislation includes punishments for anyone caught violating patient privacy. And get this, those who do so for financial gain can be fined upwards of $250,000 or jail for as long as 10 years. Even accidentally breaking the rules can result in penalties, embarrassment for you and your organization, and you could even lose your license. So it's very, very, very important. HIPAA is a serious thing. All right, so policies for receiving verbal orders in an emergency. In most facilities, the only circumstances in which an attending physician, a physician assistant, or a nurse practitioner may order orders verbally is in a medical emergency when the physician or nurse practitioner is present, but isn't able to write the order. So they could be in the middle of the situation, things could be happening fast, they might be just saying things out loud, and they can't get to a computer, maybe the computer's down, who knows. The order must be given directly by that physician or that nurse practitioner to a registered professional nurse or a registered professional pharmacist who receives, reads back, documents, and executes the order in readback, quote, readback is what we call. The recipient which is where the recipient reads back the message as he or she heard it and interpreted it. This gives the person giving the order then confirms that such recording and interpretation of the order was correct. Verbal orders may not be given, received, or executed under any other circumstances. So the registered nurse or the registered professional pharmacy who receives that verbal order is going to record the order in the patient's medical record. They're going to read back the order to verify the accuracy of the order. So the nurse is going to say, Dr. McDonough, I see that you ordered 25 milligrams of IV metoprolol IV push as a one-time dose to be administered right now for high blood pressure. The doctor will confirm the accuracy, whether or not you're accurate or whether or not it needs to be changed. You're going to record the date and note the time that the orders were issued during the emergency, and then you're going to record the verbal orders, the name of the physician or the nurse practitioner who issued those orders, followed by the nurses by your own name or title. You're going to review the orders. Immediately after the conclusion of the emergency, the physician or the nurse practitioner, whoever issued the verbal order, must come back and review the orders to ascertain whether or not they are correct. They have to sign that order with their name, their title, their phone number, and then they have to date and note the time that he or she signs the order. Then the registered nurse must see that the orders are transcribed according to the procedure. And that everything is in place. So that's a big responsibility. I have actually never but one time been given verbal orders, and that was several years ago for just some IV fluids. And that's because a doctor was driving, and then when he got home, he put the order in. So it's not something that I see all the time. It could occur in different settings more often, but not in a setting where I work at. But that is the policy that we would follow if we had to get a verbal order. So what is the purpose for recording data? So today we have increasingly significant, sophisticated management systems that manage our information, and they help manage patient-specific data and information. These records contain data that's used to help facilitate quality care that's evidence-based, patient-centered. It serves as a financial and a legal record, so it helps our coding department goes through our electronic health records, and that's where they bill insurance companies so that we can get paid. It's a legal record. If something happens with the patients, we can go back and see, the course of the history, what's documented. It can help in clinical research. It helps support decision analysis. And information specialists aim to create an environment that supports timely, accurate, secure, and confidential recording and use of that patient-specific information. Patient records also have many other purposes. The American Nurse Association states that the most important of these is communicating within the healthcare team and providing information for other professionals, primarily individuals and groups involved with accreditation, credentialing, legal, regulatory, and legislative reimbursement, research, and quality activities. So communication is the primary purpose of the patient record, and that helps other healthcare professionals from different disciplines who interact with the patient at different times to be able to communicate with another. Communication will foster a higher continuity of care. We use it to use for diagnostic and therapeutic orders. So patient records, anyone viewing the chart can find every diagnostic study that has ever been ordered for the patient since admission. It will show the results of the studies that were ordered and any care or related orders to that outcome. Illegible handwritten orders and typos have been the source of many errors. This is why most places have electronic health systems, because they have mechanisms in there to help decrease these errors, and they're not handwritten. Oh, excuse me. Whenever you are unsure of what has been written or entered in an electronic record, go back and check the order. Never guess about what's written. It's always good to go back, check that original order, and if you have any question, you follow up with the person that wrote the order. If you don't, it's your patient's life and your license that are literally at risk if you incorrectly transcribe or execute an order. So you always want to make sure that you understand what you're reading, and it's okay to ask questions. Care planning, so each healthcare professional works along with the patient to assess the patient's baseline, and then they compile an ongoing data so that they can see how the patient is responding to the treatment from day to day. Part of our ADPI, right? Implementing. So quality, process, and performance improvement. So we use documentation as the primary source of evidence, which is used to continuously measure performance outcomes against what we consider predetermined standards. So records can be reviewed to evaluate the quality of care that patients have received and the competence of the nurses that are providing that care. So you have heard, I'm sure, or you will hear that accrediting agencies, facilities such as like the Joint Commission, make surprise visits to your facilities, and they use record reviews to determine whether a particular facility or healthcare is documenting properly and keeping proper patient records. They perform audits, and it helps to improve the quality of care that the patients receive. When the Joint Commission comes in, they literally come in, they pick a unit, they find a nurse, and they say, pull up this, pull up that, show me where you document this, how do you handle that? That's literally how they do it. It sounds pretty terrifying, but it's a good way to make sure that we're doing what we're supposed to be doing, and ultimately it helps keep the patient safe. The other purposes of patient records, we can use it for research. Researchers may study patient records hoping to learn the best way to treat a certain identified health problem, or from other studies of similar cases. And it aims really just to promote that evidence-based practice in nursing and deliver that higher quality of healthcare. It helps with decision analysis. So information from record reviews often provide the data that we need by administrative strategic planners to identify needs, as well as the means and strategies to most likely address these needs. It has educational purposes, so healthcare professionals and students read a patient's record can learn a lot about the clinical manifestations of certain healthcare problems, how we, what kind of treatment modalities we use that are effective, and then any factors that can affect the patient's actual ability to achieve their goal. We use it for credentialing, regulation, and legislation. So the documentation allows reviewers to monitor healthcare practitioners and the healthcare facilities' compliance with standards that govern that profession and their provision of care. Again, it's a legal documentation. Patient records are legal. They might be used in evidence in court proceedings. 1 in 4 malpractice suits are decided on the basis of the patient's records, what they find, what's documented. Documentation always plays an important role in implicating or absolving healthcare practitioners charged with improper care. The record can also be used in accident or injury claims made by the patient. No nurse can afford to be ignorant or careless about facility policies and professional standards regarding documentation. You have to take it very seriously, and you have to make sure you're doing it properly. It's also used for reimbursement. This is how we demonstrate to insurance companies the treatments that we've provided and how we want to get paid. And then it's also historical documentation. So because all entries on the records are dated, the record has a value as his historical document. Years later, you can go back and find information that concerned a patient at a certain time, and it's considered historical because you have that timeline there. So there's 2 types of personal health records. You have a standalone personal health record where the patient fills in information from their own records. This information is stored on a patient's computer or the internet. And then you have a tethered connected personal health record, which is linked to a specific healthcare organization. it gets linked to their electronic health record system or to a health plan's information system. So many people today like to prepare online personal health records, we call them PHRs, and they want to be able to manage their health via a computer. These records, like we said, can contain their medical history, any diagnoses that they have, any symptoms that they experience, medications that they take. Patients can scan in their doctor's notes, their test results, any CT images, any insurance information. They can give healthcare professionals their passwords that they can log on and view their record. They can share it with their family members. And the main reason why patients have this PHR is because they want to provide easy access for up-to-date, complete health information, because it helps assist in self-care and it helps communicate with their providers. So it's a great thing to have. The benefits of a healthcare information exchange: an electronic health information exchange allows the doctors, nurses, pharmacists, and other healthcare providers and the patients to appropriately access and secure a patient's vital medical information electronically, which will improve the speed, the quality, the safety, and the cost of their patient care. It's appropriate, timely sharing of vital, important patient information, which can better inform decision-making at the point of care, and it allows providers to avoid readmission and medication errors, improving diagnoses and decreasing duplicate testing. The benefits of a healthcare information exchange includes providing a vehicle for improving quality and safety for those patients and the care we provide. It provides a basic level of interoperability among EHRs maintained by individual healthcare providers and organizations. It stimulates consumer education in patients, and it involves them in their own healthcare, which is probably, in my opinion, one of the best benefits, because we want patients to be active in their own healthcare. We want them to be autonomous. We want them to advocate for themselves and know what's going on with their healthcare, so that they can advocate for themselves if they are ever hospitalized. And it helps the public health officials meet the commitment that they've made to their community. It creates a potential loophole for feedback between health-related research and the actual practice itself. It facilitates efficient deployment of emerging technology and healthcare services, and it provides the backbone of technical infrastructure for leverage by national and state initiatives. So methods of documentation. There are many, many methods of documentation. We're going to go over these kind of quickly. There's a lot here. So you have your source-oriented records. So many nurses, especially nurses that work in rural or undeserved areas, they continue to practice in offices and settings that don't use electronic medical records. They still use the traditional paper records, and they come in a different variety of formats. There's all kinds of paper formats. The source-oriented record is a paper format which each healthcare group keeps data on its own separate form. There are sections of the record that are just designated for nurses, different healthcare providers, laboratory results, x-ray personnel, physical therapy, occupational therapy. Your notations are entered chronologically, with the most recent entry being nearest the front of the record. An advantage to the source-oriented record is that each discipline can easily find and chart pertinent data. The main disadvantage is that the data is fragmented, makes it difficult to track problems chronologically with input from groups of professionals. Then you have problem-oriented medical records, so it's another type of paper record. It's used in some facilities, and it's basically problem-oriented. Problem-oriented medical records is basically organized around a patient's problems rather than around sources of information. All healthcare records record information on the same form. The advantage of this form is that the entire healthcare team works together in identifying a master list of patient problems, and they contribute to collaboratively planning their care. Progress notes clearly focus on patient problems. So you could use the SOAP note. Some people call it a SOAP-E. I just call it a SOAP, subjective data. It includes the SOAP note includes subjective data, objective data, assessment, and then a plan. If you're doing SOAP-E, it's subjective data, objective data, assessment, plan, intervention, and evaluation. And then if you do SOAP-ier, the last one would be response. The R would be for response. Then you have pie charting, which is your problem, your intervention, and your evaluations. There's a lot of different types of documentations you can use. The pie charting system is very unique. It does not develop a separate care plan. So the care plan is just incorporated into the progress notes, which identify problems by number in order that they are identified. The documentation system is a patient assessment is performed and documented at the beginning of each shift using pre-printed fill-in-the-blank assessment forms. We call them flow sheets. The provider documents any patient problems that they are identifying through these assessments. They become numbered and documented in the progress notes, and they work up plans using problem, intervention, and evaluation format, PIE, P-I-E, problem, intervention, and evaluation. And they are evaluated each shift. Problems that resolved or dropped from the daily documentation, and continuing problems are documented and numbered each day. The one advantage of this system is that it promotes continuity of care, and it also saves time because there's no separate care plan. You have focus charting. The purpose of focus charting is to bring the focus care back to the patient and the patient's concerns. So instead of a problem list or a listing of nursing or medical diagnosis, a focus column is used to incorporate all the aspects of a patient and their care. The focus may be on the patient's strength, their problem, or their need. And topics usually appear in the focus column, and they include any kind of patient concerns or behaviors, any therapies and any responses to their therapies, if there's been any change in the patient's condition, and any type of significant event that has occurred, any teaching or consultations the patient's had, any monitoring that they require, and then how the patient's monitoring their activities of daily living. We have charting by exception, which is what we do where I work. It's basically, they say it's a shorthand documentation that makes use of well-defined standards. So for our computers, we, when we're going through all the systems, we document if there's no issues within normal limits. And then if there are issues, that's when we go into more detail and we put in more documentation. So we document only by exception, so whatever the problem is. You have case management models, which we don't deal with. That is emphasis. Those models emphasize quality and cost-effective care that's delivered in a certain time frame. That's more so for your case managers. Then you have computerized documentation, electronic health records, which is what I work with at work. Everything's on a computer. You can look in your book. And there will be a whole bunch of ways that you can read about the ways that electronic health documentation is positive for you. It does help you provide a higher level of quality care, safer care for your patients. It helps better provide and manage care for your patients and it provides accurate, up-to-date information. It's complete information about the patients at their point of care. It enables quick access to patient records, and that will allow for more coordinated, efficient care. It's securely sharing electronic information with your patients and other clinicians. It helps providers more effectively diagnose patients, which helps reduce medical errors and provide safer care. It improves patient and provider interaction and communication, and it helps promote legible, complete documentation and accurate, streamlined coding and billing. So this is a sample of a healthcare note that's handwritten. You can see here that here's the date. This is the focus of the note. So they were at high risk for trauma. Down here at 10 o'clock, the focus was their pain. At 10:30, that was their pain. So the data that we put in was the patient crying when I entered room, confided that she is afraid to go home because her injuries are the result of her husband's battery. What action did I take? The attending notified and discharge canceled. The abuse network called with patient's permission, and they are sending a counselor this afternoon to talk with her. So you see how right here, you have the last word of that sentence, her, and then the period, and you have all this open space. So that's what I was talking about. You draw that line right through there, and then you draw that line right through there, and then you put the first initial of your name, your last name, and then your credentialing information behind you. So nobody else can come in after you write this and write anything else. Okay, that's what I meant when we were talking about that earlier. We're going to practice writing a note. We will do that. So the major components of a problem-oriented medical record, you have a defined database, you set up a problem list, you have care plans, progress notes, and then that SOAP format. So when you're using that SOAP format, you have subjective data, you have objective data, you have the assessment, right, which is the caregivers, the nurse's judgment about that situation, and then the plan. What's your plan going to be moving forward? So your formats for nursing documentation, you have that initial nursing assessment, which is typically in most facilities in electronic form that you use to record that initial database that you obtained during your nursing history and physical assessment, okay? You accurately document this data because this first assessment that you make, that initial nursing assessment, that provides the baseline for later comparisons from anyone who comes behind you, and it helps to quickly identify patient condition changes. You have your care plan, which is your patient care summary. It records patient records, must communicate whatever your patient's problem is, that nursing diagnosis, okay, any related goals, what your outcomes are for the patient, any interventions that you have implemented to help obtain that goal and that outcome, and then the progress you're going to evaluate, right? And you're going to document that progress or the resolution of the problem. The nursing care plan can be written separately or incorporated into a multidisciplinary plan. If it's an electronic health record, there's a whole section just for care plan. You have your patient care summary. This contains an overview of valuable patient information, such as your documentation, lab results, test results, doctor's orders, and medications. You have what we call critical collaborative pathways, which the case management plan is very detailed. It's a standardized care plan that is developed for a patient population with certain designated diagnoses or procedures. It includes expected outcomes, a list of interventions to be performed, and the sequence and timing for those interventions. You have your progress notes. The purpose of these progress notes is to inform caregivers of the progress a patient's making towards achieving their expected goals. The method used to record the patient's progress just depends on the documentation system that you have. You have flow sheets and graphic records. These are used to record and certain routine aspects of nursing care. So some of the graphic records that you will see will be, they display your vital signs. It displays your blood pressure readings, your pulse rate, your respiratory rate, your temperature. It can document your weight, your strict eyes and nose, your bowel movements, your output, all that good stuff. Then you have your MARS, or your medication administration record. This is the patient's medication record and includes documentations of every medication that has been ordered, every medication that's administered. It keeps track of the dose, the drug that was ordered, the dose, the route it was given, the time it was ordered, the time it was given, the nursing administration of that drug, the reason why the drug was administered, and its effectiveness. Acuity records are 24-hour reports which are increasingly used in conjunction with acuity reports. I don't use these at work, but nurses can use these to rank their patients as high to low acuity in relation to when they look at the patient's condition and the need for nursing assistance and interventions. This is very helpful. Often we use acuity rankings to determine staffing requirements. So a nursing unit with patients with higher acuity rankings would require more nurses than a unit with the same number of patients who have lower acuity rankings. You have discharge and transfer summary. So when a patient is discharged or transferred to another facility, there is a discharge summary that is written and printed that concisely summarizes the patient's reason for admission. Why did we treat them? What do we treat them with? What significant findings did we find? What procedures were performed? Any treatments that were rendered? What's the patient's condition upon discharge or transfer? And then we would want to convey any specific pertinent instructions given to the patient or the family. These are usually electronically. We print them off. If they're being transferred to another facility, we give them to the facility that's picking them up. Or if they're being discharged, we give this information to the family members or the patient. Then you have long-term care documentation. So this is documentation in a long-term care setting is different, and it's specified by what they call a resident assessment instrument, an RAI. This helps the staff gather definitive information on a resident's strengths and needs, and it can address these in when they create individualized care plans. The RAI helps staff to track changes in a resident's status and by evaluating resident goal achievement and then making appropriate revisions to the care plan so that the patients can meet their goals. This is an example of a graphic record, and this over here is a paper form of a 24-hour fluid balance record. If you do work in a facility that requires paper, they're all going to look different. Every facility has their own thing. This is your medication record here. This is another example of a medication record. Medicare requirements for home health care. In order for a patient to receive home care at home, the patient has to be homebound and still needs skilled nursing care. So maybe they have a wound that needs to be changed, or they're getting IV antibiotics. So they're homebound, they can't get out to go into the facility to get that IV antibiotics, or they need IV antibiotics for a certain amount of time, 6 or 8 weeks. They don't have a ride to get to the facility every day to get that those antibiotics, or maybe they don't have access or anyone to take them to get their dressings changed. So they require that skilled nursing and they're homebound. That's a requirement. Their rehabilitation potential is good. We want to know that we're investing time in these patients and their rehabilitation is going to be good. It's a good potential that they are going to make a recovery and lead a productive life. Or if the patient is dying, then they would have hospice service. The patient's status is not stabilized. So if they're not stable, they're still going to require care. We're going to want to send a healthcare nurse out to see them. And then we want the patient to be making progress in his expected outcomes of care. So the patient's going to continue having home care. We're going to continue applying those that skilled nursing care, but we want our patient to be progressing in the right direction. We've set expectations for them and outcomes. They're achieving them, but it's just taking a little bit longer. So we talked about those RAIs in the long-term care facility. So the components of those assessment tools. So the minimum data set, that's a core set of screening, clinical and functional status elements that form the foundation of the comprehensive assessment of all residents in long-term care facilities that participate in Medicare or Medicaid. The items in the data set set standardized communications about resident problems and conditions. They have triggers, so specific residents' responses for one or more of a combination of minimum data elements identify residents who are either at risk or who have developed specific functional problems and who require further evaluation using resident assessment protocols. We have resident assessment protocols, which are structured frameworks that are problem-oriented, and they help organize minimum data set information and examines additionally clinically relevant information about the residents. The resident assessment protocol helps identify social, medical, nursing, and psychological problems and forms the basis of really developing that individualized care plan for the patients. And then you have utilization guidelines, which are specified in state operation manuals that direct when and how you should use RAIs in the long-term care facilities. The benefits of an RAI. So we want these RAIs must be completed for residents of Medicare, skilled nursing facilities or Medicaid nursing facilities, hospice residents, and short-term stay or respite residents who reside in a facility for longer than 14 days. The benefits of using an RAI is residents respond to individualized care. So their care is based on their needs. It just makes sense that if you individualize their care, patients are going to respond in a positive manner. The staff communication becomes more effective. The resident and family involvement increases and documentation becomes clearer. So those are the benefits of having an RAI. Handoff communication, or ISBARR, to report is to give, and when you're reporting, you're giving an account of something that you've seen, maybe something that you've heard, something that you've done, or something that you're considering. So reporting is oral, it can be written, it can be computer-based communication of patient data to other people. The Joint Commission has included managing handoff communications among its 2009 National Safety Patient Goals. The Institute of Health Improvement is promoting ISBAR communication technique as a framework for communication between all the members of the healthcare team about a patient's condition. So the ISBAR is identify and introduce. So that is communicating who you are, where you are, and why you're communicating. Your situation is going to be communicating what is occurring and why the patient is being handed off to another department or a unit. You're going to give that background again, what led up to the current situation, and put it in context if necessary. Assessment, give your impression of the problem. What do you see? What do you think is going on? Recommendation, explain what you would do to correct the problem. And then read back of orders and any response that you get from the provider. And you can also go to page 475, box 19-6, and you can read more about that. So now we have change of shift and handoff reports. Change of shift is usually, or handoff report as they call it, is from primary nurse to primary nurse. So the nurse that came in at 7 a.m. got report from the nurse that came in at 7 o'clock at night the previous night, or depending on however the shifts work. Different hospitals have different shifts. So it's report that happens from one nurse to another. And it is the nurse who is taking who's been responsible for the patient all night is going to give report to the nurse who is assuming responsibility of the patient and going to continue to care for that patient. It can be in a written form, it can be orally. Today, the trend is to do that bedside report. So you would want to go into the patient's room, you want to stand at the bedside, you want to introduce the nurse that's coming in. You want to let the patient know that you're leaving, and then you want to give that report about the patient. So why are they here? What's going on? Code status, any pertinent information, what happened during the day, review their medications, review nursing orders, and establish patient goals for the upcoming shift. This helps you identify any safety patient needs. Is that bed alarm on? Is the patient hanging out of bed? Do they have to go to the bathroom? You want to help them up before they try and get up on their own and fall. It allows the other nurse coming in to put eyes on that patient and make sure that everything's good. It provides a smooth continuity of care, and it involves the patient in their care, and it allows that patient to speak up and say, hey, this is what's important to me. These are my goals. Or maybe they can remind you of something that you forgot, because sometimes we forget things. We're taking care of 5 people. It's possible to get our patients confused sometimes. So we want to include that patient in their care. You would want to talk about any abnormal occurrences during the shift, any unfilled orders that need to be continued on to the next shift. Not everything gets resolved in one shift. Some things are in limbo, so you want to let them know what they have to handle. If there was any patient or family concerns or needs, you want to make sure you give that and report. And then you want to report on any potential transfers or discharges. So if your patient is probably going to be discharged tomorrow, you would want to make sure that you tell them, hey, this patient was supposed to be discharged today, but they didn't get to go home. Everything is set for tomorrow at 2 o'clock. You'll hear more about discharge in the morning. So then we have, let's see, telephone and telemedicine reports. So if you're giving a report on the phone and you're calling, you want to identify yourself, right? You identify the patient and your relationship to the patient, that you've been their nurse for the day. You want to report accurate information about the patient, any change in the patient's condition that could be of concern, what's already been done to respond to this condition. You want to report the patient's current vital signs and any clinical manifestations that they have. You want to have the patient's record at hand so that you're making knowledgeable responses to any physician's inquiries. You don't want to guess, right, and say the wrong things. You want to make sure you have the time to give an accurate report. You want to make sure you have everything you need, that electronic health record, that paper health record, whatever you need at hand. And then you want to concisely record and date and time of the call, what was communicated, what was the physician's response, and who you actually talked to. These are all important information that you want to document. Conferring about care. Sometimes patients need consultations and referrals. They can have some problems. So we as nurses can detect problems, but we cannot resolve them because they're outside of the scope of our practice, right? So we have to let the doctors know, and they can make referrals. So if you see that your patient's not eating properly, or you think they need a supplement like a Ensure shake to go with their lunch, you would want to meet with the doctor and say, hey, I think Mrs. Jones could benefit from a nutrition consult. Do you think you could have someone from nutrition come and see her? Or I see that Mrs. Jones is really having a trouble eating. Do you think we can do a swallow study? Can we have someone from speech come and evaluate? Maybe she needs a different type of a meal order. Maybe she needs ground or chopped instead of a regular whole diet. So you can certainly make those recommendations. Nursing and interdisciplinary team care conferences. So anytime there is a plan to coordinate care about your patient, you're going to be involved in that, okay? It involves the practitioner, it involves you, it can involve physical therapy, all the members of the healthcare team that we talked about. And then you have nursing care rounds. Rounds occur usually every day on every unit. You go in when it's time to talk about your patients, and then their case manager's there, the doctor's there, usually the pharmacist is there. They talk about why the patient came in, what their treatment plan is, and then you talk about any concerns that you have with the patient. So that's what we call nursing care rounds. So the benefits of nursing informatics, what benefits do we get out of it? Well, it increases the accuracy and the completeness of any nursing documentation, because we know that if it's not documented, it's not done. And we know that documentation can serve as a legal record years down the road. It improves the nurse's workflow and an elimination of redundant documentation. It is an automation of the collection and reuse of nursing data. And there's a facilitation of the analysis of the clinical data. So those are the benefits of nursing informatics. And guess what? We are done. This was a lot of information. I know you guys are tired. You did great. Thanks for sticking with me. When we meet for our live lecture, we probably will not go over all of this again. I'm just going to hit on some key points, and then we'll open up our session for questions. So I'm sure you guys are going to have some questions, because this was a lot of information. Good job following along. And then your next lecture is going to be on for week 7. It's going to be physical assessment, another biggie, a lot of information, okay? So bring some coffee because you're going to need it. Bye, guys.